Okay, Helen, we can take it away when you're ready.
Okay. Welcome everyone to the July meeting of the Universal Health Plan Governance Board. I'm Helen Belanca, I'm the chair, and before we head into introductions, let's do a quick tech check. We don't have anybody virtually yet then.
No, we don't have time yet, but just a reminder for everyone, when you do speak, just please make sure to press the little button on the mic. The light will turn green, and then when you're done, you can press it and it'll turn on. Yeah, that should be good from a tech perspective.
Okay, and so let's do roll call and introductions, and Kate's going to start us off with an icebreaker question.
Okay, today's question, what was your first concert? So be thinking about that. We are going to start with Helen Belanca.
Hi, I'm Helen Belanca. My first concert was Lionel Richie. This dates us.
No way.
Yeah, my dad.
Debbie Diaz.
Here, and my first concert was at the Y100 Wing Ding. I went to see Hanson and our parents.
Yes. Warren George.
Yes, here, and my first concert was Peter, Paul and Mary.
Oh, you win.
Yeah.
Michelle Glass.
Good morning, all. Michelle Glass, she, her pronouns. My first concert, I think, was Devil Mix 3, actually.
Bruce Goldberg.
Here, Bruce Goldberg, he, him pronouns. My first concert that I remember was 1959 in New York Philharmonic.
And Judy Richardson.
Good morning, I'm Judy Richardson. I'm here. This question always stumps me because we didn't go to a lot of concerts and I just can't even come up with one.
And Cheryl Ramirez.
Here, I believe my first concert was John Denver in Red Rocks.
Wonderful. Thank you. And I did get a message from Amy. She's going to be here in a couple minutes.
Great. Oh, there she is. Hi.
Amy, you made it just in time to tell us your first concert.
I think my concert was probably.
Welcome. Okay, great. So we are getting in the habit of recognizing and thanking those who are taking the time to communicate with the board. And since our last board meeting, we've had several pieces of written public comment. Thompson submitted testimony on the sometimes unnecessarily high healthcare expenditures. He also submitted some comments and specific recommendations regarding our principles documents, which were really, really good and really interesting. Thank you for that. David Lawdig submitted testimony on metrics and processes for healthcare system improvement, and the encouragement to be specific about our quality measures and ensuring that we have the data systems to collect them appropriately, which is great. Dr. Vern Sabo, apologies for pronunciation, submitted testimony regarding preventing reimbursement discrimination against licensed providers in Oregon, specifically chiropractors. And I want to point out that that requirement is already specifically called out in the legislation that created this board remote work, is that we are not discriminating against any licensed provider who is working within the scope of the plan. So Kate has posted all of those documents on the website. Thank you for that. And one can read those in more detail if you're interested. Quick agenda review. This morning, we've asked a couple of our board members to share their knowledge on topics that are of interest to the board, community engagement and behavioral health. We'll also hear from Jenny on a couple of follow-up issues to a presentation she did last month on other states' efforts around single-payer healthcare, universal healthcare. We have a couple of board agenda items where there may be action today. We may be approving the additional values and principles from the work group, approving the work plan, and possibly approving goals of this group, and then establishing formally the committees that we talked about last month. Good. Cool. So next we need to approve the minutes. Did anyone have a chance to look at the minutes? Anyone have questions or corrections on them?
Move we approve the minutes.
Second.
Great, any discussion? Katie, would you roll call?
Helen Blanca,
Yes.
Chen Wei Chi,
Yes.
Deborah Diaz,
Yes.
Amy Fellows,
Yes.
Warren George,
Yes.
Michelle Glass,
Yes.
Bruce Goldberg,
Yes,
Judy Richardson,
Yes.
and Cheryl Ramirez.
Yes.
Oh, great, so Katie, we've made note that John Ritchie has joined the meeting as part of roll call. Hi, John Ray, welcome.
Thank you. I wish I could be there, but I have to go to school this afternoon.
That's okay. We did a quick intro question on what your first concert was. Do you have a?
First
have-
concert,
first
you
concert?
mean the concert I attended?
Yes,
Well, the first concert I attended was a classic music concert in Taichung, Taiwan, when the new concert hall was established, and the first concert was Beethoven's piano concerto.
wow, very nice. Can we adjust the volume?
Yes, I will work on that.
Okay. Great, next we have the executive director's report. Morgan, will you give us an update on what you've been working on?
Great. Thank you. I'd like to share a couple updates about bringing on additional capacity to support the work that we're about to embark on. First, we've been working with our OHA colleagues on the additional 2 limited duration positions that OHA has to support the work. Those positions were posted for several weeks and that recruitment closed on Sunday. Jenny and I are going to be involved in the interviews for those 2 positions, and OHA is looking to bring those folks on in early fall. So hopefully that will coincide with when the committee work is starting. So we'll have 2 additional full-time people to help support the committees, which I'm really, really excited about. In addition to bringing on additional staff capacity, I've been having lots of meetings with the procurement folks here at DCBS. And we've started the process for a much larger RFP that to bring in additional research and financial capacity to support the really the research and the financial analysis that will need to take place for the committees. That process will take a lot longer and will take as long as 6 to 9 months. So that puts us out to February. So the additional work that we've been doing is trying to meet that gap. And have been working with the OHA on accessing their technical assistance bank. This is a list of contractors that they have some additional relationship with and basically start a mini procurement or a best value analysis. And when OHA goes through that process, then we can enter into an interagency agreement with them, which is a much shorter process of a month or 2. So we're looking to bring in that capacity in a very short amount of time and to coincide when the committees are really starting their work.
6 to 9 months seems a long time for procurement. Is there any way that that can be expedited? I mean, I know there are within, not all state government contracts take 9+ months to procure.
Yep, in my meetings with the folks here at DCBS, to have the size of contract that we want puts it into over the amount that DCBS has the authority to do. So first we have to ask DAS, the Department of Administrative Services, to give DCBS the authority to run the procurement, which can take a month or 2. And then it will need to go through a legal sufficiency review because it will be over $250,000. So there's a couple extra steps that are in there that it doesn't seem like can be expedited, which is why we're trying to do the short-term support with OHA to access their TA.
Is there any way to divide it into 2 contracts or something, or is there? We stuck with that?
Yes, that would be an option. In discussions I was having, we didn't want to go that route because I think that there is some risk in that work that is needed to support the committees could fall through the cracks if we bring in, 2 or 3 different contractors to do the assistance and not one that has kind of that global perspective. So we decided to go the larger route with these kind of 2 approaches, accessing the TA bank and then the larger procurement.
Thank you.
So we're hoping with the access to the TA bank, that we could bring in a contractor that would, that would be for a year. And so it would overlap with the larger procurement to make sure that we have that support, while we're bringing on the larger contractor.
Morgan?
Yeah.
I'm so sorry to interrupt. This is Michelle speaking. Does this impact in your mind the timeline or the work plan as they've been, work plans as they've been drafted so far?
It did not. I think that we're trying these 2 approaches so that we can appropriately staff the work plan. And we'll bring on the capacity as soon as we can.
I'm just a little confused about what, it sounds like you're just getting one contractor. It would be important to know what kind of skills we're looking for, how many contracts, etc. You made it sound like we're just getting one contractor for over 250,000, but yet we've got some needs around revenue, we have some needs around pricing, we have some needs around communication. So could you lay out what kind of contracts and
Yeah.
how much money?
Yes, thank you for that question. So, there are kind of 3 buckets and 3 approaches right now that we're pursuing. One is for the communications and community engagement. We're currently working on a scope of work that will be a smaller procurement for, I think, 50 to 100,000. So that's a smaller procurement. The second is accessing the TA bank in an agreement with OHA for research and policy analysis to really focus on the health system analysis that we need to get going. That will be for a year to support the committees. And then the third is a larger procurement where we're trying to bring on one contractor to do health policy, some additional analysis, policy analysis, and the financial piece, and that would be a larger contract for as much as 500,000 or more.
The financial piece, are you looking for the same contractor that will help us with revenue as well as the same contractor that would help price the benefit? They seem like 2 really different skill sets, and I would wonder about the ability of a single contractor to do that.
Yeah, for the revenue piece, I've started conversations with the Legislative Revenue Office to see if they can continue to support the revenue analysis and and that would not be part of the contract, figuring out the taxes, and that would be work we would do with the Legislative Revenue Office. So that's not included in the larger procurement.
I think it would be helpful to have some outside expertise for revenue.
Yeah, and we did talk about this a little bit, so I think there were a couple of different ways we thought about approaching it. One was, should we identify all the needs that we have? We need to assess, what are the revenue options and how would those play out? We need to do some financial modeling around the plan and how it would work. And we need to think about how to transition the work that we're doing. And we could sort of put those in small buckets and say, okay, we need somebody to help us figure out this piece and then this piece and then this piece. And contract with 3 or 4 different people along the way for all of those different things. Or we could look for a firm that was big enough to look at our whole plan, understand what we need. They could do some subcontracts if they wanted, but we would have like a general contractor kind of that really focused on the finances of what we're trying to do, the financial modeling, the revenue piece, the economic impact on the state. That somebody who would be really strong in the financial aspect of it and could do all of those three things, even if they needed to subcontract that out. But we would be asking them to come on sort of as a general contractor for the project, understand what our goals are, understand what our deliverables are, and then could meet all of those deliverables either on their own or with subcontracts. We were thinking, and this is up for discussion a little bit, but we were thinking that having one firm that was big enough and had a big enough contract that could get us to our goal would prevent, as Morgan said, things falling through the cracks or address, like, we anticipate that this is going to be a difficult iterative process where we're going to encounter things that we didn't expect or have questions that we can't identify right now. And we wanted somebody who could work with us along the way as the plan evolved, and figure things out as we went and could, be, ultimately accountable for our final deliverables, as opposed to trying to figure out everything right now and doing separate contracts. It was kind of a judgment call, if we should do a whole bunch of small contracts for each of the questions or one big general contractor. We landed on the one big general contractor. It felt like a way to have a little bit more flexibility and have sort of a firm that understood the final goal and could help us be accountable to that. But that's kind of our thinking on it.
Thank you, Helen. Well said. Yes, and yeah, that was the thinking and the approach.
We talk about what's the timing of preparing the RFPs or RFQs? When will they be written or how?
Yep, so as I mentioned, the first step is for DCBS to request a delegation of authority from the Department of Administrative Services to be able to run the procurement, because it's so large. So we're in that process right now, and that would take 1 to 2 months. And while that's happening, we're drafting the scope of work. So we're trying to start the process at the kind of in parallel. So as we've been developing and having conversations about the work plan, that work is then informing the scope of work that we're developing for the RFP.
Yeah, and I would say that there's one large sort of contract with sort of this general contractor person. We really want that to focus on the financial piece, financial modeling and revenue and, I'm sorry, thank you. And economic impact. We really want to find somebody whose expertise is around the finances of how we would do this from start to finish. And so we don't expect that person would also have expertise on community engagement, right? And so that's why we thought that would be a separate, we'd have to look at that separately and see what our goals were around community engagement and what we needed, and that would be a smaller contract. But those are easier because it will certainly be less than 250,000. We'd be able to contract that more specifically and more quickly. But that's this big, like our biggest need is around the financial piece, financial impact and modeling. So we wanted to aim there first.
I have a feeling we'll talk more about this as time goes on.
Yeah, the last update I wanted to share, I know there have been questions about kind of budget for the next biennia, and as the Universal Health Plan Governance Board is under the umbrella of the Department of Business and Consumer Services, we've been part of their process to put their agency request budget together. So we've been working on drafting a narrative, and our budget will just continue in with their budget as a part of their current service level budget. The biggest changes to that budget from what the legislatively adopted budget are in supporting the 3 full-time staff. Because the legislature approved the budget, knowing that there would be a gap to get us up to speed and to bring staff on, I think they supported 2.65 FTE, and now that will roll up to the full 3 FTE. And then there'll be other adjustments and roll-up costs in that budget as it goes forward. And then as you know, once that budget is submitted to the governor's office, then the governor will work on her recommended budget, and then that will go to the legislature, where the legislature will make the decision for the next fiscal year in the next legislative session.
Sorry about that.
So we are working with DCBS on that process, and it's moving forward. And that would also, I think the other piece to highlight is that we have our consultant budget for this fiscal year, which is one more year of this in this biennia. And then we would also have a consulting budget of 500,000 for the next biennia as well. So that would double the resources available for us to finish the work. Yes.
Does that mean that we would have to spend down our current budget by next June 30th of next year, or it goes back to the state?
That is correct.
So that, I guess that to me also makes the challenge of the long procurement. It's another challenge related to the long period of time that the procurement might take, especially since that's the largest chunk of money.
Yes. And that's why we're trying the other two smaller procurements to get going.
And so when you say 6 to 9 months for the procurement, are you saying it'd be 6 to 9 months before we can put out an RFP?
No,
Right, okay,
sorry, that's from the beginning to bringing
to
the
hire
contractor
somebody.
on.
It might take as long as 9 months to hire somebody, but we would get the RFP out
Yeah, yes,
in 3 to 6 months
yes.
and then hire.
Yes,
Sooner.
and then they would be, the idea is that, if this took as long as 9 months, that we would have somebody on board with a contract, starting the work in February.
Thank you.
Hopefully closer to the 6-month mark, but, as long as. Yes.
Okay, so we're gonna move on. Thank you, Morgan. Next, we have a presentation from Michelle Glass and Amy Fellows on community engagement.
Thank you, Chair. Good morning, everyone. I am Michelle Glass, and I am one of the public engagement members of the board and co-chair with Amy Fellows of the soon to launch community engagement work group. And in fairness to my co-chair, I do just want to state that this presentation's been in the works for weeks. Amy and I just became co-chairs, and so I invite her input as I present, but I did not put her on the spot at the last minute to co-present fully. So she's just invited to.
But I did give input last week.
Yes, she helped you with the presentation, so thank you, Amy. And please jump in at any point. So, so today, I know that this is a topic that y'all are familiar with already to a certain extent, to varying extents. And some of you have done this work in your previous roles as a task force. So this is really, my focus today is to talk about some specific tools that we can use in our work that are best practices for public policy and public engagement. Talk a little bit about the great foundation that we're building on from the task force, community engagement work, the charge that we have specifically under Senate Bill 1089, and then tie that to the community engagement work group's initial priorities, and then invite a little bit of thought partnership from all of you in the remaining couple minutes. So, oh, perfect. So public engagement, of course, broadly refers to engaging members of the public in decisions that impact them. And there's broad consensus that public engagement is a critical component of public policy, and a lot of good evidence that it results in better outcomes for everyone. So some of the reasons that we've prioritized this, not just this particular board, but throughout the process, starting before Senate Bill 770 was even drafted, is because we know that good public engagement results in policies that are more effective because they align with the needs, and as our colleague Chunwei would remind us, the values of the population that it's intended to serve. It also can it helps us to achieve one of our guiding principles
and values, which is community ownership over the universal health plan itself. And so of course that needs to start early and remain consistent. And then it is also our opportunity to build understanding and to build that support that we need for this to be successful. People need to know what it is, right? And where we're at in the process and how they can participate if we're going to have that understanding and support. And then finally, I think we all have a responsibility to be transparent and accountable, which is written into the legislation, Senate Bill 1089. But that's beyond a legislative mandate that also helps to build and maintain public trust, which is critical to efforts such as this. Next slide, please. Oh, it's not showing up. That's weird. Oh. Okay, well, what you can't see, the invisible ink on this slide is 7 principles, which are very similar to 4 principles that were used by the Community Engagement Task Force. And those 4 principles were simplicity, completeness, credibility, and trust. And I think that's a great distillation of this longer 7 principles that were developed by the Public Engagement Principles Project. And don't despair, even though you can't see them here, there is a longer handout that I think is really useful that staff has, thank you so much, has put under the board resources tab on our website. And it not only lays out what those 7 principles are, but it talks about what they look like in practice. So the first principle is careful planning and preparation. The next one is inclusion and demographic diversity. The third one is collaboration and shared purpose. The fourth one is openness and learning. The fifth one is transparency and trust. Then we have impact and action, and finally, sustained engagement. So this is one of the tools that I am hoping we can use, not just in the community engagement work group, but any of us who are engaging with the public to guide that work and make sure that we're adhering to best practices. And then similarly, you know, the good news is we don't have to reinvent any wheels. There are lots of great public policy engagement professionals that have developed these models. And there's a lot of evidence about how well they work. So this is another example. So this is familiar probably to those of you that were on the task force. This is a modification of a really common spectrum of public engagement that was developed, excuse me, by the International Association of Public Participation. And my hope in including it here is not to argue which side of the public engagement model we should engage in, but to actually say that we need to hit all 4 of these buckets if we're going to do this effectively. And this is just a way for us to evaluate as we work with our limited resources like time and money, to make sure that we aren't expending all of those resources before we get to each of these forms of engagement. Additionally, ensuring that we're aligning the type of engagement with the goal or the need at the time. So on the left-hand side of this model, we have the more passive forms of engagement, such as informing, right? So the goal is to make sure that has reliable, credible source of information if they want to know more about the project. And we already have that with our website, with the fact sheets, so that the task force developed. So that's great. As we move along this continuum to more active or proactive forms of engagement, we have consulting. And this is really the listening and asking that we've been talking about, this is a 2-way communication engagement process that we want to be engaged in. And so this is things like public comment, which we already have opportunities for. And I want to echo Chair Blanca's appreciation for the folks who are taking the time to share their input with us, but also things like the focus groups that the task force engaged in, and things of that nature. As we continue to move along the continuum, we have involve. There's a current opportunity for involvement, which is participation in the working groups that we're setting up. And that's really co-developing with members of the public what this is going to look like and how it's going to operate. And then finally, we have collaborate. And collaborate is something that the values and principles work group talked about a lot in terms of how do we involve members of the public, not just in developing the plan, but in governance itself on an ongoing basis. And you see some examples of how that's been done for other even universal health plan projects in other places, like the advisory committees. Next slide, please. And oh no, more invisible text. Oh, that's so strange. Well, if you use your imagination, you can see a lovely quote here by Douglas Adams from his famous book, Perfect. Warren doesn't have to use his imagination, he printed the slides. Way to be prepared. There's this famous book called Hitchhiker's Guide to the Galaxy by Douglas Adams, who is a British satirist. And I think it's of course, meant to be funny, but I think it really points to something that is very real. So I'm going to read the quote to you. But first I want to ask, how many members of the board believe that, what percentage of Oregonians is aware that there is a website for the Universal Health Plan Governance Board? Do you think it's like more than 20%? Not zero. More than 5%? No. Okay, so really, I think that's the point. Those of us who are on the board, those of us developing these resources, we know that they're there, and so they are visible to us. But for the vast majority of Oregonians, it's not accessible, and therefore that level of transparency is not as effective as these more proactive forms of engagement, which is why we need the full spectrum. So the quote is, Douglas Adams is having the character in the book is having his house knocked down to build a new freeway. And he goes to the planning department and he says, when was this decided? And they said, oh, the plans have been on display for a long time. Why didn't you see them? And he said, well, where were they? So he eventually has to go down into the basement, but the stairs have gone out. Then he goes into a disused laboratory and he finds the plans finally at the bottom of a locked box with a sign that says, beware the leopard. So that illustrates the very real barriers that people who are not engaged in this work with us encounter in knowing that there is something to look for and then where to look and then how to find it, right? And so it's really on us to make sure that we have transparency through accessibility. Slide, please. So starting before Senate Bill 770, but certainly with Senate Bill 770, there has been this commitment to good public engagement throughout the process. So that bill included a direction to the task force to engage in robust public policy engagement, which they did. And similarly, Senate Bill 1089 continues that direction to us, and it actually gives us some really specific folks that the legislature wants us to focus our engagement on. We'll talk about that in a second. And similarly, the Universal Health Plan Task Force, in their report, directs us or intends for that work to continue as well. The foundation was laid with the engagement work that was done there, but it's clear reading that report that there is more work to do. Next slide, please. So this is where we stand in that long process. So in section 2 of Senate Bill 1089, we are asked to engage with specific groups of folks in a really intentional way, and that includes the 9 federally recognized tribes, existing boards, commissions, and councils related to healthcare and insurance, a broad range of healthcare professionals, including providers, coordinated care organizations, insurers, and also regional organizations, so that we are tending to the various complexities and challenges that may be different in different parts of the state. But this bottom paragraph here, to me, is the heart of our chart under public engagement. And it says the components of the Universal Health Plan must be accountable and fully transparent to the public regarding information, decision-making, and management through meaningful public participation. So I have had such a great time reading through the task force report. Thank you to those of you who were part of that work. We build on a strong foundation. The task force did public engagement with more than 230 community members in virtual sessions in spite of some challenges. This was 2022. I don't know that engagement went quite as everyone thought it would at the beginning, but a lot of really amazing feedback that's actually too much feedback to summarize in this presentation will form the foundation of our efforts in community engagements. We have that to build on. In addition, there were 37 healthcare professionals, employers, and union representatives that were engaged in intentionally small specialty forums to give really detailed feedback throughout that process. So we have all of that feedback that will, next slide, please, will inform the beginning of our community engagement work plan. So we are gonna actually, once we have our committee seated in August and September, we will start there. We'll review prior public engagement materials, which includes the task force report, as well as community health assessments from across the state, and other community engagement reports from good work that's already gone on, so that we can start with the feedback that Oregonians have already been given, and then build on that. Then in October and November, we're going to be developing communications and outreach plans and materials, which we will bring to the full board for your input and approval. And then if this all goes to plan, we should be ready to implement those approved outreach and communications plans in November, or I'm sorry, in December and January. So that is what this workflow looks like. And to get us off to a strong start, we need the help of everyone in this room and everyone who's joining us virtually to share the committee recruitment materials. So certainly we want folks to apply for the Community Engagement and Communications Committee who have interest, relationships, and experience in that work, but also Finance and Revenue Committee, Plan Design and Expenditures, and Operations and Transition workers are also open right now, and those close at the end of the month. So please apply if you're interested, share those opportunities with your networks. And then in addition, if folks have any places or people or groups that you think we should be reaching out to as we begin this work, that is part of our work plan, is to start with existing networks, meetings, places. So please send those ideas to me and myself. So I've got two slides left, and I just want to wrap up with a couple of thoughts that Amy and I have been kicking around as we think about how we open up lines of communication, be more responsive in our public engagement work. I've been thinking a lot about how to do that within the really important public transparency rules around, this board and how it operates. And my understanding is that the full board has to authorize anyone who is engaging with the public. So one idea that I had was, and that I shared with Amy and we were discussing, was maybe this board could appoint people who are leading in various ways. So our chair and vice chair, the chair or co-chairs of any of the work groups that are members of the board, to do public engagement. And that would give us a little bit more flexibility to be responsive instead of getting emails we can't respond to, or directing people to public comment, which often doesn't involve a direct response. I think that might help with the flow a little bit. And then for accountability purposes, having a report back monthly on what that engagement looked like. So that's one idea that I would propose. Another idea that actually came from a community member who reached out and asked for an update. And I said, I'm sorry, I can't come and give you an update right now. And they wrote back and said, what would it look like if you all included a short agenda item at the end of meetings to talk about what are the report outs from this meeting? My understanding is that may have been part of the task force at times, or some of how that work went. So I thought that was a great idea to bring forward. So thank you to Lori Open for that. And then after reading the task force report, I also was recommending that we offer both online and in-person opportunities to engage. I think online is accessible in a lot of ways. And also it sounded like reading between the lines, maybe a little bit, having it only online, maybe limited some participation. So it'd be nice to be able to do some of each. And then additionally doing tandem engagement with targeted and broad constituencies instead of a phased approach. And that's just to account for the human tendency to not want to be last. And so, within our constraints of time and capacity, to just say everyone is top priority and here's how we're rolling that out instead of having phased approaches by group. So those were some of the thoughts and reflections that we came up with to bring to you all. And then finally, I would just welcome any of your best thinking on how have you seen this go well? What's worked well to engage diverse, broad stakeholders? Or what are things you think we should do differently based on things we've seen in the past? And what are your hopes and ideas for public engagement in this work? And I welcome questions, responses to any of these ideas and prompts now or at any point throughout the process. As we've said, this is going to be iterative. So this is really the beginning of a conversation.
This is great, Michelle, and Amy.
Yes, Michelle did most.
But I really like this approach, and I think it's well-grounded. Anxious to put it in play. Thank you.
I think.
Or-
Yeah,
I think you.
you go ahead.
Oh. I agree, this is great, Michelle, very well thought out, and as one of the task force members who participated in the focus groups, I totally agree with you, we've got to do some in-person focus groups, they can't all be online. I also think we need to be careful to make sure the people that we recruit to be involved in these groups are that we have diversity, and I'm not talking racial, ethnic, yes, and also experience, because I think maybe there were, at least in the behavioral health sector, and I think I said this before, but I just want to reiterate. I think the people who were recruited just came from a certain demographic group, and I think we need to go broader at this time.
Go ahead.
Okay, I just wanted to say, yes, fabulous presentation, thank you so much, and we're really excited about this. You mentioned on the last slide that to have the chairs be appointed. I wanted to bring it up to this group that, in my opinion, I think all 9 of us should be able to report out. It's not going to be up to Warren and I. And you don't even necessarily have to be a committee chair to do it, but I think all 9 of us as members of this board should be able to report out on the work of the board, to update the groups that we're involved in, to talk to our communities about what we're doing. And I would like to suggest that and make sure that you're all okay with it, that any one of us could do that. There are a couple of guidelines around that that we've thought about. One is that, yes, we have a standard PowerPoint slides that already exists that we could add to each month to update the work. Right now, it just has sort of our values and principles and then the work plan. But as the work progresses, we can keep adding slides so that you use that PowerPoint as the basis of your conversations. That you inform us, like that you would let us know, like, I'm gonna be talking to this group and here's what we're gonna be talking about and the date, because we wanna be able to keep track of that and know when that's happening. And that you will have a PDF document also of the written talking points, exactly to your point. I agree, we should have so we'll have a written PDF with talking points. Here are the things that are going on, here are the things that are, that we've decided, and what our plans are in terms of the formal work of the board, and that you stick to those. And then if you are in engagement with the public and they ask a question, or they ask you to, talk about some other topic that goes outside of that, that you just make it clear that at that point you're not speaking about the board's work, that you're speaking for yourself personally, and your personal opinion on that topic. So yes, so it would involve letting us know, sticking to some basic talking points and the PowerPoint structure, and then being really intentional about knowing when you are reporting on the work of the board versus offering your own opinion or thoughts on something. That would be like the 3 part thing, but then we could all do that. Is everyone in agreement with that? Can we do a quick fist of 5 that all 9 of us should be able to talk about our work? Okay, we got 5, 5, 5, 5. Yeah, we got 5s all around, and Chun-Li's got 5. Great. So yeah, and yes, I would like to make a standing agenda item, starting with our August meeting on community engagement. And at that meeting, we kind of review what the new talking points will be. We ask people if they've had discussions with communities, what they're, do you have any talks planned? If you've done talks already, where did that go? And we just keep that as a standing agenda item so that it's always on our radar of how we're communicating with the public. Is that good? Cool. Any other thoughts, comments, questions on that, Bruce? Did you want to?
So, one, I echo everything that's been said, great presentation. I saw that you've expanded from just being community engagement to communication and community engagement. Thank you. I think that's really important. And I hope you're thinking about that as 2 somewhat distinct lines of work. How we engage the public is one piece, but I think it's really important how we talk about our work in general and communicate. And I think we could use some help in that. that's really different from the help in engaging the public. So, great, I see you're nodding your head. Yeah, that's really important. And I'll give you offline some resources of some places that might help with that.
Thank you.
I don't want to belabor the point. Thank you again, Michelle. It was a great presentation. Along your question of what have you seen that has worked well to engage diverse stakeholders, and wondering what we can learn from our efforts during the pandemic with the OHA getting vaccination information out there. And if the task force was involved in developing a network or a compendium of the community-based organizations that may or may not have healthcare touch points, but were instrumental in engaging, wasn't perfect, but a wide base in getting the information out. Thank you for your work. And second, thank you for adding. That's a great suggestion. Warren.
I was just going to say that as early on, I was one who urged caution in talking to the public, because when, like the first meeting, we didn't have much to report. So we're moving from all conjecture and no experience to now we've actually got a game plan that we're putting together. There's just more that we can talk about and besides just conjecture. So I'm very much on board on opening the gates to more communication now.
Great, so as a summary,
Chenwei also has
oh,
comments.
Chenwei, I'm so sorry, yes, go ahead.
Yes, thank you very much for Michelle and Amy's very informative presentation about public engagement. I have some kind of question or clarification about the next step. In a very roughly speaking, public engagement can have at least 3 levels depending on the purpose, and each level gets more intense. So the most primitive level is informing the public, such as during the pandemic, informing the public about important issues. And that tend to be one way, and for our purpose, that's a bit outdated. And the second level is through two-way communication. Particularly, we want to get the public's input about their concern, their interests, and their value. And then the third level is the most intense, is if we have some important value preferences, we would really want the public to intensely participate in the policy making. So the third level is the most intense. So my question is, in our future public engagement, how shall we develop strategies for those at least 3? There are other purposes. At least these 3 important but different function and require different intensity and perhaps different method of public engagement.
That's noted, but I have a different comment. Oh, good. You guys going to respond to that issue?
Thank you, Chenwei. Yes, that is absolutely part of this conversation, is how do we ensure that we are being intentional to do all of those types of engagement within, and that we plan for it so that we have the resources for both the intense, as you say, forms of engagement and the deep listening forms of engagement, as well as the passive forms of engagement, that we don't, move through our time and financial resources before we get to and fully capacitate those other forms of engagement is definitely something we're thinking about. So thank you.
And then I just wanted to connect back slide 9 where we have kind of our timeline. And connecting that back to the executive director's report about bringing on communication consultants so that we can kind of make sure that we have that timing right, so that we get some guidance on that.
Great, thank you. So we have another speaker and I want to move on, but I'll say it in summary that we will be sending out an email to the board that summarizes the communication piece for now, which will have the basic PowerPoint, the PDF of talking points, and then kind of the guidelines for how to talk to the public for all of you in terms of letting us know and and that kind of thing. So you'll get that as a follow-up to this meeting. And we encourage you to go ahead and start, talking to people about the work we've done so far and what our plans are. And then starting in August, we'll have a standing agenda item where we revise that and keep everyone updated. Okay. Oh, excellent. So next we're gonna be turning over to Cheryl. She's gonna be talking to us about behavioral health in Oregon, and you, Cheryl.
Thank you. Good morning, everyone. I just wanted, turn on mic. I just want to note that the sunrise and the horizon is my way of depicting hope and optimism for the behavioral health system in the future. So with that, I was asked to give a brief overview of the behavioral health system funding structure broadly as it pertains to significant federal policy that has impacted state systems, that is, and more specifically, the funding structure in Oregon. My focus is on the public behavioral health system, which I define as the delivery system that serves people who are Medicaid eligible, uninsured, and underinsured. And the services may include community-wide services, and by that I mean across the lifespan, regardless of insurance. So it could be any of those types or not insured. And these are services from mental health promotion and prevention, like population health initiatives, to crisis response. Think of the fire department. That's what we strive to be like. I use mental health and behavioral health somewhat interchangeably, although the term behavioral health commonly refers to both mental health and substance use disorder related services. So I just want to make mention of that. Next slide. So I'm going to start with a little history of the community mental health system. Really, the beginning was with the Community Mental Health Act that passed in 1963. And this was to really deinstitutionalize our system. A lot of people were institutionalized for many, many years or perhaps their whole lives. And so the vision was to help people recover, get their care in their own communities, and live a full life. Unfortunately, the vision didn't get fully realized because it didn't get the funding. The funding didn't follow the people from the institution to the community. So we've been trying to catch up ever since. In the 1960s, states established community mental health centers. In Oregon, we call them community mental health programs, and county-based delivery systems to implement the Community Mental Health Act from 1963. States like Oregon who have implemented county-based delivery systems are California, Texas, Michigan, New York, Pennsylvania, and others. So this is not just an Oregon unique thing. In 1975, the Community Mental Health Act was amended to add federal definitions to ensure that access was open to all the communities, like I mentioned earlier, community boards, and to make community mental health centers have a federally qualified status. You may be very familiar with community health centers. They're also considered federally qualified health centers. And so at the beginning, community mental health centers were set up just like FQHCs. So there was another amendment in 1980, because of time, I won't go into these in detail, but in 1981, the Mental Health Systems Act was repealed. Community mental health centers lost their federally qualified status. And instead, the federal funding was block granted through a federal agency called SAMHSA, a Substance Abuse and Mental Health Services Administration. And that's how we're funded today. And the funding still comes in two separate block grants, one for mental health and one for substance use disorder, even though we're trying so hard to integrate those two areas of care. And a lot of the people we serve in the public behavioral health system have co-occurring disorders. So in any case, so there were two major federal efforts to move to more parity between physical and mental health, and to make sure people got access to the behavioral health services they need. And so I'm just going to cover those very briefly. First was the 2008 Mental Health Parity and Addictions Equity Act. And second was the Certified Community Behavioral Health Clinic Demonstration Program in 2017. I'll just cover those both a little bit. So next slide. So first, the Mental Health Parity and Addictions Equity Act. This was signed into law by President George Bush in 2008. And it applies to all, really most health plans except for Medicare. Even though the concept of parity is simple, the federal parity law is incredibly complicated. And so it's been difficult for insurers and health plans to implement some of the more complex components of the law. It's been really difficult for state and federal regulators to implement, provide guidance. And in fact, even this year, there's a comments period going on right now with changes to the reporting requirements and final rules. So they're still tweaking it. Okay, next slide. So as states experienced the federal mental health parity law and implementation of that, it seemed kind of slow and sluggish and wasn't really fixing the problems. States started introducing their own legislation, starting with model legislation that was crafted by California. Oregon was one of those states that introduced its own legislation in 2021, House Bill 3046. And basically the core tenets of this legislation are reporting requirements by the insurers and Medicaid MCOs, or in our state, the CCOs, to kind of prove that they're following parity requirements. There are also requirements for the insurance department in Oregon, that's DCBS, to enforce parity. And then third, there are reporting requirements for DCBS and OHA to show what they found from the reports from the insurers and the CCOs. It also clarifies that mental and substance use disorders must be defined as in DSM and ICD. DSM is diagnostic and statistical manual of mental disorders. ICD is international classification of diseases used to code and classify medical diagnoses. Because we don't have a whole lot of time, I'm not going to go into the first two reports that DCBS has provided to us, the 22 and 23 report. I'll just say, I'm sure this comes as no surprise to you, but there's variation across insurers on denial rates for behavioral health. Behavioral health provider rates have still been found to be consistently lower than physical health rates. It's hard to assess the NQTL parity, that's non-quantifiable treatment limitations parity, because we have data quality issues. And they found in the 23 report that telehealth utilization is increasingly prevalent as a method of behavioral health service delivery. It's one of the reasons why we're losing workforce for the public system, honestly. Okay, now I want to go to the CCBHC demo.
Cheryl,
Yes.
I wonder if you could take a moment to just explain what's meant by parity.
Yeah, that's a good question. It's what we want to get to is that there are no more restrictions on access to mental health care as there are to physical health care, and that providers are paid equitably. I think those are the two main components, which would result in people who have behavioral health needs get access to care and get good care.
So my experience of this work is that kind of historically we've thought of mental health and substance use disorders as sort of social problems and funded them sort of as social problems and less like a health problem.
Exactly.
And so because of that, we haven't traditionally paid providers. We've paid them low wages and kind of in a system that doesn't work the same as the physical healthcare system,
Right.
because we've never really considered it a health problem. And the goal with the parity laws then is to really integrate, you know, in terms of we now understand that mental health and substance use problems are physical health problems, and that they're essentially the same and really components of basic health, and therefore they should be treated and paid for.
It's a great way to explain it, better than mine, and that they're medically necessary,
And that they're medically necessary.
and they're not just social problems.
And insurers should cover it.
Yeah, and insurance should
Yeah.
cover it, and providers should be paid
Yeah,
at a level that's on par with what physical healthcare providers are.
and not all these pre-authorization requirements, utilization management types of things. So, very good explanation. So going on to the certified community behavioral health clinic demo. as we were seeing parity roll out and thinking, wow, this isn't really solving the problem. There was a bill called the Excellence in Mental Health Care Act of 2014 that tried to get to parity a different way, which was through the providers in terms of payment, really is the main thing. So this led to a 2017 Certified Community Behavioral Health Clinic, I'm gonna call it CCBHC if you don't mind, demonstration project. Oregon was one of the 8 states, and still is, it's still a demo project, that got this resource, which was an enhanced federal funding in the form of a RAP payment. So CCOs would negotiate a certain rate, they pay that rate, and then Oregon Health Authority fills in the rest of the RAP payment is kind of how it works in a very non-technical description, but so that's still in a demo until September 2025. And I wonder if the RAP payment sounds familiar. Yes, it's the same way that FQHCs are paid. We're trying to go back to 1975. So as we see the end of the demo on the horizon, we wanted to make sure that CCBHCs are sustainable in our state. So we were able to pass, this is just a little section of House Bill 4002 from this past session, which is the Measure 110 fix bill. And so it sustains the CCBHCs. Currently there are 12, by the way, 12 CCBHCs. And enable other community mental health centers, community mental health programs who qualify to become a CCBHC to be certified through a state plan amendment after the federal demo is over. So that's how that works. Next slide. I'm not going to go into this. I just want to say that the biggest differences between CCBHCs and community mental health programs or community mental health centers, there are 2 things. One is the way they're paid. So CCBHCs are paid through a PPS, prospective payment system. Again, that is that RAP payment that FQHCs receive, same way. And the second thing is that CCBHCs have a requirement to provide primary care. In Oregon, it's 20 hours a week. It's mostly screening, but some CCBHCs have hired nurse practitioners to help to do that work. Or they've contracted maybe with FQHCs to help them out, or contracted, with an MD, for certain numbers of hours a week. So those are the 2 major differences. Otherwise, CMHPs have all these requirements that CCBHC do. So I want to switch gears a little bit just to review the continuum of community-based behavioral health services in Oregon. This is a chart, for the adult continuum of care. I don't have time to go over everything, so I chose this one. This chart was created by Multnomah County and presented to the Oregon Health Authority in the 2023 session, just to give them an overview of what community mental health is. The continuum spans service categories from prevention on the right here to the highest level of care that we have in the behavioral health system, which is the Oregon State Hospital on the left. I just want to note that the Oregon State Hospital has a separate budget from the rest of the behavioral health, the community behavioral health system continuum. It's completely separate. It's mostly funded by state general fund because the state hospital is an IMD. That means Institution for Mental Disease. I know that's a terrible name, but that's from the 1960s. So that's just what it is. So that means that they may not be funded by Medicaid because they have more than 16 beds, way more than 16 beds. So that's something we've been also arguing against for a really long time. Okay, next slide. So this is showing the continuum another way. And this pyramid depicts the services we should really be providing more of on the 2 bottom levels and spending more on to prevent the escalation to crisis and acute care at the top of the triangle pyramid, or legal system involvement. In reality, we're spending a whole lot of time and money on the top 3 sectors there on the pyramid. If we compare to European countries, their human services spending, those 2 lowest tiers, is 72% of their total healthcare spending, while in the United States it's 53%. So according to Health Management Associates, and these are 2018 numbers, if the US spent this, same percentage as European countries, it would mean $1.19 trillion more on human services spending. Next slide. This is a very simplistic graphic of how funding is distributed in the public behavioral health system. On the left are the main funding sources for the public behavioral health system. They primarily go through the Oregon Health Authority, the county or community mental health program, and CCOs. CMHPs and other public behavioral health system providers operate within a complex system of funding streams and payers, many of which have separate and sometimes conflicting guidance and reporting requirements. And public behavioral health system providers are not reimbursed for excessive administrative tasks, burdensome rules, reporting requirements, and multiple audits. And that's another reason why we have a workforce exodus in the public behavioral health system. Next slide. So here's a typical community mental health program funding mix. This is an average, so I don't think this will be a surprise to you, but about 60% of our funding comes from Medicaid. Next largest is 30% from state general funds, and the state general funds includes the SAMHSA block grant funds that I told you about, the mental health and substance use, that are incorporated into the contract community mental health programs have with the Oregon Health Authority. So it's part of that. Next is the 5%, and I grouped the county general funds and the burn dollars together because most community mental health programs do not receive county general funds. Only the very largest counties, only the community mental health programs for the very largest counties receive county general fund. Burn stands for Behavioral Health Resource Network. These are entities that are funded through marijuana tax revenue. As you may recall, ballot measure 110 moved all the marijuana tax revenue into this account, and then burns receive funding for treatment. And most of our community mental health programs do receive burn funding. They are participants in their burns and are now very reliant on it for substance use treatment. So 3% more or less are federal grants that they apply for on their own. They're competitive. And 2%, no, that's not a typo, is the combined revenue from commercial insurance, Medicare, and the VA. Yeah, 2%. And of course, this is going to look different for private practices and hospitals. This funding mix is going to be entirely different. So next slide. So obviously we have reimbursement challenges in the behavioral health system. And I just wanted to note the data from Mental Health and Addiction Certification Board we call MACBO. The behavioral health system has an equal proportion of licensed and unlicensed providers. It's literally about 50-50. We in the public behavioral health system are completely or almost completely reliant on unlicensed providers. And unlicensed providers are more diverse as a group than licensed providers. Just a couple of high points here that the services that are provided by unlicensed providers are for people who have the highest mental health needs. And they're almost solely covered by Medicaid, state general funds, and the federal block grants. Most of the team-based, multifaceted, or capacity services, and by this I mean like wraparound services for kids, let's say, or the crisis services that are 24/7, and we have to pay for that capacity just like firefighters. They're not fully reimbursed by payers because they don't fit into the billing codes. And then licensed mental health clinicians have an additional hurdle that they have a 2 to 3 year internship after they get licensed, and they need all these hours of supervision, which are either paid by them with their student loans too, or by the host agency. Okay, next slide. So I'm left with a few questions, and this is why I volunteered for the finance and revenue and plan design work groups because it's just so different for the behavioral health system, and I want to make sure that I know what's covered in the universal health plan. So these are my 4 questions. One is on the service array. Are supported housing, education, employment, and social needs services in or not? Provider type, are these unlicensed clinicians and peer support specialists that we rely on in the public system, are they covered? And facility-based care, are services for people in institutional settings, which are extremely expensive at the Oregon State Hospital, and then jails and prisons, are those included in the Universal Health Plan? And you may be aware that the Oregon's 2022, 27, 11, 15 waiver is scheduled to cover transitional services for certain populations, including those who are in carceral settings in 2026, which is a great development and something we've advocated for 20 years at least. And then last, will we continue to rely on the current funding to cover the public behavioral health system services and providers, or to fill gaps? So that would be the state general funds, federal block grants, and then the marijuana, tobacco, and alcohol taxes. So I just want to be really clear on what's in and what's out. It's very important to me. So those are my questions for us as a group, and I'm happy to try to answer any questions you might have.
Thank you, thank you, thank you. That's exactly what I wanted you to talk about this. Every time I think that the healthcare system is a mess and complicated and problematic, then you just get a little wind of what the behavioral health system is dealing with, and they're nowhere near. It's a whole different level of complexity and problem. I just want to point out that one of the reasons I asked Cheryl to do this talk is because when we think about combining all our healthcare dollars into a single fund in order to pay for services, it gets really complicated when we talk about behavioral health, because it's 30% general fund plus all these federal grants and other grants. And so thinking about those as healthcare dollars, as we should, makes this a little bit complicated, and we really have to call that to mind. We have an opportunity with this work that we're doing to change the way behavioral health is paid for in Oregon. And this whole project that we're doing is an enormous opportunity, but especially around the realm of behavioral health and how we think about it, how we pay for it, how we think about our workforce and support them. Our legislation requires us to treat all licensed providers the same. And then your point about unlicensed providers is a really important one. So I'm super grateful to have Cheryl on this board, and we're going to be, really needing to think about what are we going to do differently about behavioral health to make the system function in a simplified, equitable, and effective way. I think that's an enormous challenge that we really need to put a lot of work into. So thank you for this introduction, and this is just the tip of the iceberg, I think, of what Ever.
Thank you so much for that presentation, Cheryl. I have a quick comment and then a question. My first comment was just in that kind of triangle of funding, and looking at that very bottom, it just makes me think of Maslow's hierarchy of needs. And I wonder if having a document for those who might not be familiar might be helpful in understanding that a bit. My question would be in regard to the exodus of workforce. I'm wondering if you have numbers, percentages, or resources you can share on the latest with that, and certainly post 2020.
It's a great question, and it's one of our biggest problems right now. Let's see. We don't have numbers. I don't have numbers to share with you today. We're collecting the workforce gaps in preparation for the 2025 session because it's such a big issue. We not only need higher rates in the public system to incentivize people to stay, we need to reduce the administrative burden. And I mean, telehealth is great and it works for some people. It's the best thing for some people, but in the public system, we've got to be face to face. We can't just rely on telehealth. It's not possible. You can't respond to a crisis event, for example, by telehealth. You can start there, but someone's got to be there in person. So I think we need to be creative about helping people stay in the public behavioral health system with higher rates, more incentives, maybe like housing. In some places, they can't even find housing for themselves. Childcare, bonus payments, moving costs. I mean, there are a lot of different things that we'd like to see. And we've got to prioritize those services and the people we serve in the public system so that we don't have that. People continuing to leave, because it's really at a crisis point. Not sure if I totally answered your question, but I can come back with numbers after we collect.
Yeah, I hope we're gonna continue a hybrid approach because having someone in my life who's agoraphobic, if we didn't have telehealth, they would not access services.
Oh, yeah, for sure, yeah.
But what I was gonna say is a very concrete example, and I'll send you the petition later, but a provider, a neuropsychologist in Eugene, there's a petition that is going around because the insurance companies will no longer cover evaluations for children, or after they have done the testing, the insurance companies, including CCOs, are refusing to pay. And so the person, so this person is now cash pay only, so it's $4,000. So it's completely inaccessible, and then the only other option in Eugene is the CDRC without, 1 to 3 year wait list. I'll share with you later.
That's sad, and I'm afraid it's not shocking.
Yep. Other questions or comments?
Just a quick comment. This is great. I think we're gonna also need, I mean, this is the kind of, Cheryl, I think as you know, the previous task force said, well, we need enhanced behavioral health services, but never defined it. Gotta clearly define some things, and I would say the same thing needs to be done for services to help care for people with disabilities.
Yes.
Many of the same issues, and we're gonna need to be really clear about that.
Absolutely, yes.
Great.
And it's many of the same people. Because
Yeah.
ableism causes mental health issues.
Yep.
Definitely co-occurring issues.
Amy, did you have another comment?
No, that was it.
Oh, sorry. So we need to take a break. I'm wondering if Jenny, we can give you a few minutes at the start of our meeting after the break to do your follow-up. Is that okay?
Yeah.
Okay, let's take a 10-minute break now. Come back at and 10:30. Let's just come back at 10:30 and then start there. Great. Okay, thanks. So next on the agenda, was Jenny back? She's not back. We're gonna have Jenny do a quick update on the multi-state health policy talk that she did last week. She has some additional items in our materials.
Can we do a, sorry, a quick tech check, please?
Oh, quick.
Chenwei, can you hear us okay?
Yes, I can hear you.
Wonderful, thank you.
That's better.
And we can hear you.
Yes, we can.
I guess we should just move on.
Yeah, I would, oh, here she is.
Okay, great.
You're up. Welcome back. Yeah, oh, come on up.
Yeah, so at the last board meeting, we asked Jenny to come back and provide some information on a couple of additional states. And so she is here to follow up on those Colorado, Massachusetts, and Maryland's efforts, which weren't included last time, so.
Hi, everyone. I'm sorry about the delay. It's my. Good morning, everyone. Sorry about the delay. So also, I just wanted to say, in consideration of time and the rest of the agenda, I'm going to keep this fairly short since I provided a little bit of a write-up on it. I was just kind of going to go through the slides and give everyone an opportunity to talk a little bit about it in questions. But I know some of the agenda items we're going to have a little bit later may take some time. So I'll be kind of quick about it. So the requested follow-up included follow-up about Colorado, Massachusetts, and Maryland's healthcare initiatives. In addition, there were some questions around what other states in the country are looking at universal health plans. And then finally, there was a follow-up question in the last presentation. I talked about California's efforts currently in universal healthcare. And there was a question about how they were defining long-term care services, because their plan had said initially, and in their the legislation that was passed said that long-term care services should be included. And so, next slide. Colorado's health policy initiatives recently do include single-payer legislation, which is a bill that's been introduced a few times, but recently, and something that's probably of interest, was Amendment 69, which was a amendment that was brought by proponents of single-payer access in Colorado, but wasn't supported by the Colorado legislature. And it was brought as a ballot measure, which usually requires signatures to get it on the ballot, and so they were able to get it on the ballot. The measure itself did not do well. It lost by 79% of the vote. I should say 79% of voters voted against it. And I can't tell if that was something that was anticipated as the measure was coming through, but in some of the materials that I found about the measure, there were some very specific things that weren't taking into consideration that they thought maybe led to the failure of the ballot measure. Those included things like not really reaching out to some of the public interest groups and community engagement and partners that they might need to build a strong coalition in order to pass that measure, and some conflict in terms of ensuring that there was no conflict of law in the measure, which were things that I wanted to point out to us as we go into this work. We've talked a great deal about how important community engagement it is, and how important it is for us to be engaging with partners to ensure that we are hearing their concerns about the work that we're doing. One of the issues with the ballot measure was around abortion care, in that the state of Colorado has in their constitution a restriction that does not allow any state funding to go toward abortion. And the anticipated outcome of the single payer amendment would have essentially closed down private insurance in the state. And there wasn't enough communication, at least from what I've seen, there wasn't enough communication between proponents of the measure and healthcare providers and abortion proponents in the state to understand if that was going to actually effectively end abortion services in the state. And so it's a really very specific but good example of what can be left out if we aren't really talking to all of the people who are involved in the healthcare industry. Additionally, some of the constitutional requirements in Colorado around voting were at odds with this system. As I said, the system was created entirely outside of the Colorado government. So the board would have been a completely separate entity in no way affiliated with the government. And it created its own voting system. Unfortunately, in doing so, it sought to create a broad network of people to be able to vote, included those with undocumented status. However, the state of Colorado requires citizenship, proof of citizenship to vote in the state, whereas the measure created a board that you would vote for and vote for their policies, and it didn't require documented citizenship status. On the alternative, it required that people live in the state for a year before they were able to vote on their proposals, whereas the state only required 22 days of residency. And so there were a lot of conflicts that weren't worked out before it was sent to the ballot that prohibited it from getting support from some public interest groups, from some union groups. And additionally, the measure itself only raised about $900,000 to promote it, whereas some very specific private insurance groups raised about $4 million to oppose it. And so it's hard to determine whether or not it was campaigns against the measure that ultimately led to it not being supported, or if it was that lack of coalition building that really led to it not being supported. The single payer legislation that was introduced in 2024 was passed by the House, but not the Senate. And that measure was something very similar to what we're doing here as a board, but it requested that the Colorado State University, I believe, take up looking at the issue, and an advisory commission would be created in order to start planning and building a plan, but they would be doing it also with the university as their research body. And so it would be an integrated sort of project between the two entities. That didn't go anywhere in terms of legislation for the state. And it's anticipated that we will see continuing single payer legislation be introduced in Colorado. But at this point, it doesn't look like there's a lot of champions who might be taking it up and making sure it gets all the way through. Next slide. For Massachusetts, I looked at their health policy initiative. As most people know, Massachusetts was one of the first states in the country to really enact some really change-making healthcare reform. In 2006, they created the Massachusetts Healthcare Reform, sort of how some people called it Romney Care at the time. And it was really a precursor to a lot of the things that we found in the Affordable Care Act around how it was run, and it created a market exchange. It created requirements for obtaining healthcare and requirements for employers to provide healthcare. A lot of that was amended out as the Affordable Care Act came online, and its changes, they had to become compliant with that, and the the employer mandate went away. They also have a very strong single payer movement in the state that, again, hasn't really been taken up by the state legislature, but mass care in the state is a pretty well thought out plan. They do have a financing plan around it that requires a 10% payroll tax that would be divided between employers and employees, employers paying 7.5%, employees paying 2.5%. That's thought to replace premiums that both entities currently pay. The notable exception is that they would have a 20%, or I'm sorry, a $20,000 grace. The first $20,000 for both employers and employees would not be subject to the tax. The same is true. They would have a 10% tax on unearned income, which includes things like dividends and interest and capital gains. And also the first $20,000 wouldn't be included there in that tax. Again, this isn't something that is being actively taken up by the legislature, but it's a recurrent theme and a recurrent bill with strong public support in the state. Next. Maryland. So Maryland is a bear. Maryland, as everyone knows, I think, was the only state to ever receive a Medicare waiver. That Medicare waiver that was received in 1977 has been something they've consistently had, but it's morphed a few times into different programs. So initially, the Medicare waiver allowed the state to create what was an all-payer system for hospitals, which means they got to set the price for all services that were covered under the waiver in hospitals. And so everyone that was a payer to a hospital paid the same rate, and it was set by the, Health Services Cost Review Commission that was set up in Maryland. And from what I understand, it's a fairly complicated algorithm that was set up by this commission to actually create these payments. That commission continues today in terms of helping Maryland set rates and understand what the payers and hospitals should be paying. In 2015, the state's waiver was converted, and I will share that, not being an expert on the waiver processes for this particular waiver, they've gone through several iterations, and as I understand it, it's been worked with CMS to sort of use the waiver to try new initiatives, since CMS doesn't seem to be open to the idea of providing other Medicare waivers. They've done a lot of what seems to be experimentation in Maryland. So the second iteration in 2015, instead of having this specific algorithm that paid for each individual thing within a hospital, the fee-for-service model, it created a global budget revenue model where hospitals were paid a set amount based on, again, this commission's algorithm. It set the budget for the hospital, and the hospital had to work within that budget. And the idea was to reduce hospital utilization and hospital costs. It was also to increase the quality of care that was provided by creating the care redesign program, which was created during this period to sort of manage the continuum of care in hospitals as part of this larger waiver. The waiver itself had 5 components that they had to meet in terms of whether or not they would see the program as successful. They included per capita hospital spending growth, cumulative hospital Medicare savings, reduction in hospital acquired infections, Medicare patients' total cost of care, and Medicare 30-day readmissions. In the reported data that they sent back to CMS, they met or exceeded all of these. Whether or not that's improving their system seems debatable within the people for the people within the system. In 2019, they again modified this waiver to create what's called the total cost of care model. The total cost of care model is a new program where it looks at the entire continuum of care outside of the hospital as well, but provides the hospital the ability to provide primary care incentives to continue to manage care within their work and within the hospital, to sort of create a whole system that works together. This started in 2019 and is set to end in 2028. At this point, there's not really enough information to understand whether or not this is creating benefits, but it's something that other states are looking at as well. And it seems as though CMS may be looking at as well as sort of a pilot program. You can go to the next slide. Universal Health Plan initiatives in the United States. This table comes from a report that was done in 2019 about states that had introduced single payer legislation. Vermont is called out as the only state having passed single payer legislation, but at that point, about 19 states had. Most of these states, and I will say that I looked at Michigan and New York, have continually resubmitted single payer initiatives every legislative session. They haven't been taken up yet. But as the work that we see, and we talked about last meeting on the West Coast with Oregon and Washington and California looking at plans, we may see some of that to start to filter in to those states where they're looking at creating legislation that creates planning rather than creation that implements a single payer plan. We'll go to the next slide, please. And finally, the question about the California long-term care services that came up last time. I looked through their plan and couldn't find a definition. We have been having conversations with some of the advocates from California who've been working on the legislation. And in asking them, they said that it's anticipated that the care support that is created currently under a Medicare and Medi-Cal program is anticipated to continue. And that's a program that combines those two sources of funding to provide facility-based care and home-based care. And for our purposes, the question that we were asked was I was asked specifically about individuals with intellectual disabilities. And that is covered under the Medi-Cal Medicare program. And they have 4 different types of facilities, one for the developmentally disabled, one that is for habilitative, one for nursing and one for continuous nursing care programs. And so it seems as though, as far as they know now, and as far as what they believe was written into the document when it was being created, all of those long-term care services should carry forward. They also noted that even though it's included in the legislation, that long-term care should be included. Looking at the funding, it may be something that's stepped in over time because they're not sure they'll be able to raise enough revenue to include it from the beginning and complete the care.
Is there anything about, like, because facility is basically institutionalization. So is there anything about kind of, even if it's more expensive, potentially trying to keep people in their homes and supported in their communities?
So it looks like, I will say in terms of the plan that is being created right now for the universal coverage, I don't think that they've gotten into those conversations yet. I can look into some of the notes and the meetings they're having.
Because that's really important that we don't have incentives that institutionalize more people.
I think that's a really good point. And there is a home care based model within California that has, it's not set out in terms of like, here are some bullet points that you can look at. It seems to be a more personalized approach to it, where they're actually looking at it at individuals and the individual situations. But I can't speak to how expansive that program is or how it's being incorporated at this point, but I can definitely look.
Thank you. Thank you so much, Jenny. That was a great update.
I tried to do it.
Appreciate it.
So if there are any questions or any further research items that you all would like to point out, I'm happy to take them and keep us moving.
Yeah, there's some written documentation too, right?
I'd just like to ask, there are two states, Massachusetts and Maryland, that are doing things differently than other states. So I think a reasonable follow-up question is, are there any statistics that show lower costs, better quality, better access? What are they getting for the different things that they're doing?
Great.
Sure.
We're gonna move on. Okay, go ahead.
Thank you so much for this. This is really helpful. This is Michelle speaking. One question that I had after reviewing, thank you, Amy, for the recommendation, the video recording of a recent presentation from the Healthcare for All Oregon Conference on communications, actually. They found a significant difference in public support if the term single payer was used specifically versus other terminology such as universal healthcare, et cetera. And so I'm curious, you noticed that in some of what you presented, it was specific to single payer, and I'm curious, in those states, is there a difference in success rate for the plans presented as single payer versus plans presented in other ways?
I do not have an answer to that, but I can definitely take a look because it is obvious in some states and depending on who is providing the information, that it's very clearly stated as a single payer plan. New York, for instance, all of their information about the New York Health Act says very explicitly single payer everywhere that you look at it. Whereas other states, when they're talking about whatever work that they're doing or whatever initiatives, are very much universal health plans. I haven't seen anything that says whether or not they've made that choice one way or another, but I can definitely take a look. And even if it's not explicitly stated, I can take a look at whether or not other states that have used different language are getting better response.
That's actually a great segue because the next item on our agenda, thank you so much, Jenny. The next item on our agenda talks a little bit about being really explicit about the goals of this work. As of this meeting, we are entering a new phase of this board's work. We're going to start bringing other people on board to help us out, both recruiting committee members and asking folks to join our committees to help us do the work. And as we were talking about earlier, we're going to be procuring a contract with an outside firm to help us with some of the in-depth financial analysis. And because of that, we need to be able to communicate really clearly about what it is that we're doing with this plan. What is the basic outline of what we're trying to create? And so we have recommendations from the task force. And what I'm hoping is that we can take a look at those and discuss a little bit about if those are the recommendations that we are formally adopting and saying, this is what we're building. I sent those all out to you earlier last week, so you have a chance to like really think about them and look at them, and so I want to go through them today. So I always start with the statement of the problem. This is pulled directly from the task force report. Because once we are really clear on the problem that we're trying to solve, it makes it a little easier to then say, then what's our plan to try and solve it? So the framing of the plan is basically that the healthcare system is inefficient, expensive, and complex. It relies on many sources for funding, it relies on employers to provide employment, and that results in an inequitable, high cost, inefficient system that is really financially straining for many families. That's the basic problem that we're trying to solve. And if we look at the next slide, these are the recommendations from the task force pulled directly from the report, with the only wording changes I made were to kind of simplify them or clarify a couple of points. But basically they're in here as the task force recommended them. And my goal with this is for all of us to look at these and say, yes, we're going to follow this recommendation. Or if we want to modify it, that this is our chance to modify these recommendations in terms of what our work is going forward. So if you haven't had a chance to look through these one by one, what I'd like to do is go through them and just as written in the task force report. And then at the end, we can look at the feedback that we've gotten so far on any modifications we should make to these recommendations. And then see if there are any further modifications you'd like to make before we decide if we're ready to vote on this. We don't have to vote on this today, but I think at some point, either this meeting or next meeting, I'd like for this group to say, yes, this is what we're building. This is what it's going to look like. So that we can communicate effectively with our outside partners. So, yes.
Before I make an assumption, I would assume, but I'm asking for clarification, that if we do vote on this, it would be a living document. So that if we receive significant feedback, we could amend it later as needed.
Thank you, that's a great point. So the idea with this adopting these recommendations is we agree that this is our starting point. That this is the sketch, this is the outline of where we'd like to go. And we know we can very easily predict that as we go down this path, other things are gonna come up. Problems are gonna come up that we didn't anticipate. Our intentions with these recommendations will get waylaid by various forces. We understand that, and this will need to be modified, yes. But that as we start our work and we're inviting people in, we're saying, we think this is the direction we're going, this is what we want your help with. So yeah, starting point, likely to be modified as we go. Okay. So first is that all people who live in Oregon would qualify for this universal health plan. The plan will be based on PEB benefits and will include all services currently covered by Medicaid, Medicare, and ACA plans.
You want us to comment as you go
No.
down or at the end?
No, I want to go through them all, and then I'll show you the feedback we already got. And then because it's a lot of repetitive feedback, and so we'll get to the feedback, we'll show the feedback we've already gotten, and then we can go through one by one and suggest changes, yeah. And then people who qualify for long-term care will continue to receive benefits and services through Medicaid and Oregon Department of Human Services. The plan will cover some skilled nursing and home health care. The plan will not require patients to pay when receiving care. There should be no co-pays or deductibles. Instead, people will pay new taxes based on their ability to pay. People who qualify for Medicare will be covered by the Universal Health Plan to the extent allowed by federal law. The plan will work with any individual group practice or institutional provider, including hospitals and health systems that are licensed and authorized to practice in Oregon in good standing and that provide the services in the scope of the plan. Next slide. The plan will pay providers directly. The rates of pay will be set by region to account for different healthcare needs and costs in parts of the state. Health insurance companies would only be able to offer insurance to cover benefits or services that are not offered by the Universal Health Plan. So that's called supplemental, right? I think they can only, a private insurer would only cover things that are not covered by the plan. Universal Health Plan will uncouple health insurance from employment. The plan will seek whenever possible to address social determinants of health. Members of the 9 federally recognized tribes in Oregon have the option to participate in the plan, and tribal providers can participate in the plan. And the plan will be overseen by a nonprofit public corporation. So that's as they're written currently in the task force recommendations. And then next slide, let's skip this one for now. So the feedback we've gotten so far, it's not all included here. But there was feedback on defining and verifying residency, especially considering folks who live in other states but work in Oregon and depend on their Oregon employers for their health insurance, which I think is a really big issue. Consider mentioning transition planning and implementation. Agreeing on some study parameters and attributes of a good financial plan. And then some comments about behavioral health benefits making sure that we emphasize that, including that in the plan design, in addition to the pet benefits, expanding behavioral health. The idea that we're not sure about how much the plan would be able to cover skilled nursing, and we need to have some exploration of that. There's no mention in here of any business taxes that might be part of this, only a mention of and basic income tax. And then considering whether or not we're paying providers directly, or if there's other options, including provider networks or third-party administrators could be paid. And then clarifying the role of workers' compensation. So those were late feedback that didn't make it to the slide, but that's the feedback I've got so far. So yes, so now any feedback? Yeah, go ahead, Ryan.
I support all of the task force recommendations, but I note that in the governance board, we're actually going to do things a little bit the other way around, where we started with a list of benefits in the task force, and then we tried to figure out a way to fund those. And the way that the work plan is set up is we actually come up with revenue, and then we figure out what benefits, how to assign those benefits. So just as a procedural matter, I would say that the on the first page, second bullet, dealing with pet benefits and also long-term care, that I would presume that those would be recommended exactly. Those will have to be determined by the plan design group. So I support all of the others as written.
Yeah, so so Katie can do some live editing here, and we can sort of finesse these as we go. But go ahead, Bruce, why don't you say what you were gonna say?
So the second one is confusing to me when we say will include all services covered by Medicaid, Medicare, and ACA plans. Does that mean everybody gets the Medicaid benefit?
Right, I think that is confusing, right?
So I think that I would just say the plan will be based on current pet benefits, period. I think the rest of that was really confusing. I think the long-term care piece, the first sentence is correct, but the plan will cover some skilled nursing and home health care. I would put something in there about to be determined.
Right.
I think that's an issue. The tax piece, I think you mentioned, that people will not pay when receiving care. There'll be no copays, deductibles. That makes sense, but I would probably be broader and just said instead there will be additional. We haven't had any discussion about revenue, whether that's about individual income tax, corporate taxes, how that's going to work. And the task force never came to any conclusions about any of that. And I think to come out with a statement that says people will pay new taxes based on their ability to pay probably is a little premature.
Yeah.
We haven't had any discussion around that. And then you mentioned this about the plan paying providers directly. We haven't had any discussion about TPAs.
Right.
We haven't had any discussion about regional payment authorities. I just think it's a little premature to do that. And in terms of the 9 federally recognized tribes, I think it's important to have a statement in there that current tribal healthcare systems will remain as they are.
Great. I wonder if it would make sense for us to go through one by one and get any feedback with each recommendation. So I've made some suggested edits based on the feedback that I had the opportunity to see. So if we start with number 1, all people who live in Oregon qualify for the Universal Health Plan, based on feedback I added. The plan will clarify eligibility requirements, including for people who live out of state but work in Oregon.
Or how long they've lived in Oregon. I don't know if that's gonna be.
Right,
a factor.
clarify eligibility requirements, yeah, so we need to be clear about what makes you
Yeah.
eligible. Yeah, so the plan will clarify eligibility requirements.
Eligibility and residency.
Eligibility and residency requirements, excellent,
Mhm.
yeah.
Eligibility resident requirements.
Eligibility and
Yeah.
residency
residency.
requirements. Including for people who live out of state but work in Oregon. Does that cover the concerns with that recommendation?
Yeah, the task force voted to exclude people from out of state for technical reasons, because it would require us to couple eligibility with employment.
Right, so that's the clarifying part, like what is our accommodation for, because we need to somehow define what the plan, how the plan will treat folks who rely on Oregon employers for their insurance, but live out of state. If the plan is based on residency in Oregon, right, and we don't want to couple it with employment, we need some clarification about how we would accommodate those folks, because, and I don't know how many there are, but we need to. Yeah. Yeah. But the first one, are we good? Okay. The second one, as Bruce was saying, so we should simplify this to the plan will be based on current pet benefits. And leave it at that, and then add in there, and we'll expand behavioral health benefits, because that was included.
And my question is, does that mean that people who currently receive OHP will potentially lose services?
Behavioral.
The task force was adamant that no one loses benefits.
Right.
And in some cases, OHP is better than PEP.
Right.
Yes,
So they would continue to qualify for
Right,
OHP.
yes, go ahead, so please just jump in, because it's gonna be a little bit of an intro, yes.
So could we say, the plan will be based on current PEP benefits with the goal that no one lose current benefits? But that's still subject to financial feasibility discussions, but that is the goal.
Right, is our goal to not lose OHP benefits or any benefits at all? Because I'm sure there are some commercial plans that pay for benefits that we wouldn't necessarily want to include.
I think focusing on the most vulnerable.
I think focusing on the most vulnerable is probably, I think, part of our core values.
So if we said no current Oregon health plan benefits will be lost,
Or Medicare.
Or Medicare.
I don't know.
or Medicare, we have to
Medicare part,
we
yeah,
have to be able to.
yeah, we can't,
I mean, I think that's why that sentence was confusing. It was trying to convey this idea,
yeah.
but
It just seems some of this needs to get talked through at the benefits.
Right,
It's feeling that some of this is a little premature,
In that
that
community.
these
right.
are important issues, they warrant some discussion, they need to be clearly articulated. And we may be jumping the gun a little bit.
How about if we change this to, the goal will be to have the plan loosely based on PEP benefits, but ensuring that no crucial benefits from other plans are lost, something like that. Because if we're trying to do some modeling, we have to start with some basic benefit plan. I'm not sure why the task force picked the PEP benefits, but it's like a starting point. And if we said like the plan will use PEP benefits as a starting point, but then consider other benefits currently offered by other payment systems that we don't want to lose, or something like that.
I think it was a current Medicaid benefit, current Medicaid beneficiaries would continue to receive the Medicaid benefit.
Okay, so what it says now is the goal will be to ensure this plan will be,
This will include all services currently covered by Medicare, by Medicaid and Medicare. To me, that read, everybody got the Medicaid benefit.
I see what you're saying, right. So,
Like for those eligible or for Medicare and Medicaid.
so the goal will be to base the plan on current health benefits. But will ensure current OHP and Medicare recipients do not lose coverage.
Something to that.
Will you repeat that last part, but will ensure,
That current recipients of OHP and Medicare do not lose benefits.
Current and eligible.
Yeah, it should be current and eligible recipients. It's a starting point, like if we're gonna craft how expensive is this plan, we need to start somewhere, and so looking at pet benefits, but then making sure that if you currently qualify for OHP or Medicare, that those benefits are not gonna be lost. That's the idea.
I'm wondering if we need a time check, if we're gonna go through all of these, or if we need.
Yeah. So it wasn't clear to me, so we have a little bit, a couple of more tricky ones. But then we'll see where we are. And we may need to table this discussion. This is the wordsmithing that I was hoping folks would do by email to so that we can compile it in advance. So that's why they were sent out in advance. So I wasn't sure how much, like if people had read it and had a chance to wordsmith and then we're okay with it, or so if there's more wordsmithing that needs to be done, we can come back to that. So, let's see, where are we with time? 50, yeah. So, so this is the kind of feedback that we need from you about these recommendations. We are kind of at a point where we need to move on. And so, we will do this once again. I'll send them out again. I'm gonna ask all of you board members, please, to look at all of these carefully. And is everyone comfortable with the track changes or at least highlight the changes? Please don't don't just change the wording, because then it's hard for us to track what you changed. You have to indicate to us what you're recommending that we change. So either highlight it or use the track changes feature so that we can see what you're changing. We can't do this iteratively. We can't have a communication on email. So what we can do is we can send it all to all of you once, and I can add some edits in here that we've already sort of talked about, we've already gotten feedback on. And I want you to look at them and then just send it one time to Morgan, and Morgan will compile all the feedback. But to make Morgan's life easier, just highlighting what you've changed will be really helpful. So that we can find it quickly and see if it, does that make sense? Okay, and then, but you get that sense of what we're trying to do here, is just to say, we need to communicate, if someone comes into our community and say, what are you building? You know, we need to be able to clarify that, yes.
I wonder if, I mean, we can do that, but also like hearing from the people that were on the task force with more insight on what this meant to them and other things. So I don't know if you want to, instead of just an email, like have a small subcommittee that does do that. I don't know, we don't have to, that might take too much time, but I just think it's like valuable and we learn things from the conversation too.
Right.
But we don't have time to do that today.
Were you suggesting a work group?
Yeah, like a small, just one time thing, if people want to, but we don't have to.
Let's think about it. Let's see how we do with, with one email to you after this meeting and then feedback to Morgan and a chance to do that and see how close we all are.
Okay.
And how much discrepancy there is in your feedback. If people are kind of all over the map with some of these, then yes, we're gonna have to put together a work group to kind of work through it. If people are really close and it's just minor wording changes, then I think we could compile that and bring it to the next meeting. Does that work? Okay, yeah.
And I'm fine with that. I just want to get back to a point Michelle made. If we're talking about this as a draft starting point, I'm fine with it. if suddenly we're locking in certain recommendations, I think it's really premature. So I'm okay with saying, this is where we're gonna start, but it's likely to change.
Right.
But I don't wanna be seen as voting for something where we say, oh, no, we've decided about that a while ago. I think there's some meaty issues here about long-term care, about how claims will get paid. That warrant more than just an email discussion.
Right. Exactly. So what we're hoping will happen is if we sort of if we want to make these recommendations broad enough and have them point us in the direction of where that work needs to happen. So if we want to develop a plan based on these types of benefits, then there's clearly a lot of work to do there to sort that out. And so then that's where this slide comes from, which is next steps. Whatever we decide those recommendations are, then if we want to look into those more, develop those more, move that from a recommendation to an actual plan, then we need to do a whole bunch of things. And somebody's got to really dig into what are the waivers that are possible and what are the employer options that are available? What are the benefit costs and features and how much, how much do each of those services cost and could we incorporate them? So the idea is if we think this is the right direction, and we agree this is our initial starting point with these recommendations, then we need a laundry list, and I've started one here of here's the work then of the committees. This is the call to action then. We need to sort all these issues out. We need to figure out the long-term care piece. We need to figure out the behavioral health piece. And it's a way of telling or guiding the committees to say, when you're thinking of who you're bringing onto these committees and you're thinking about where you want to start the work, these are the big problems we need to solve if these are the recommendations that are followed. Right, so it's a way to help the committees out by giving them a little bit of a call to action on a couple of big pieces of work that are still needing to work out. So it's just, are we following these recommendations or do we want the recommendation to look at something else? And therefore, what is the work that needs to happen? Yes, Michelle.
I have a recommendation, and it may seem nitpicky, but from a strategic communications perspective, I think it could be confusing and or a liability to call them recommendations if they're starting points for modeling and research. I would rather call them starting points for modeling and research or something like that. So that in public document,
Yes.
people don't take and run with.
Yes, that's a good.
Or we're gonna get a lot of feedback.
Yes.
Right, yes, that's a great point. So the word recommendations coming from these other recommendations from the task force, but you're right, we should change the name. Yes, good point. Go ahead.
Capture. Yeah, speaking to that a little bit, I was wondering with these living documents, if there was a way to explicitly have at the top for those who might be reading outside and not participating or tuning in to the meetings to say that this is a working document, the starting point, subject to change and those kinds of things. So maybe renaming it also, or doing a combination of both would be helpful.
Right, great, yes. Thank you, yeah, those are both really good points. Warren and Morgan and I will think through that a little bit and come up with some way to communicate with those things. Thank you. Okay. We'll get back to you. You'll see something about this in our first communication. Okay, so we have a couple of tasks and then we have some public comment that we have to get to. I'm gonna hand it over to Morgan right now. We're gonna try to. I didn't hear so.
Values and principles.
Oh, yes.
Was next.
The values and principles. I'm sorry, I missed that. How should we use our time here?
I think what I'd suggest is we've got two things actually to approve, and I think we can do those fairly quickly. And there's some more, I think, interesting discussion that could go with that if we could get just 10 minutes on the next agenda. I think we can make quick work of a couple of these for right now.
Okay, so I'll hand it over to Warren, and Warren, go ahead and do the value principles.
Okay, so yes, there's actually 5 of us who've been meeting 4 times. And it's been a very good group and a lot of interesting things have come up. And there's a couple of things that have come up in came up actually to the board last month and we're deferred for a little bit of clarification, and we'll move quickly through those. First, on behalf of the Values and Principles Work Group, I would like the board to approve that the board should fully endorse, adopt the Health Equity Committee's statement, pledge to complete all board work in full support of the goals of that statement in the elimination of bias in decisions and in actions, in rectifying past bias as an absolute principle of universal health care. I think everybody has read the Health Equity Committee statement. So I would just like to call for a vote.
Oh, I want a word change, sorry. I want it to say past and current bias. In recommendation number 1. I mean,
Oh,
Recommendation number 1 needs to say past and current bias. There's still plenty of ableism and racism happening.
yes, I'm fine with that.
Where it says in the elimination of.
No, in the actual, in the top, we're not gonna change the recommendation or the OHA's thing, but in
Okay.
the actual
Oh,
recommendation,
okay,
past and current.
thank you.
Okay, so Warren has recommended that we adopt this health equity definition. If someone make a motion to adopt it,
So moved.
okay, and a second. Debbie, and do we have any discussion on it or any questions?
I wanted to acknowledge the really thoughtful public comment that we got on these principles and values specifically from Thompson Sick, and I thought that the simplification of what we put together was well presented. And I agree with Warren that I think our work group did great work, and I appreciate all my colleagues on that work group. I was curious if other folks had read the comments on the way we formulated it, which I think is the same content, but what we got in public comment, I thought was simplified in presentation, in organization.
Are you proposing we change it?
Yes. I think from a communication standpoint, what was repackaged by Tom in public comment would be easier to share out with the public than I think what we had developed for our internal purposes. Is my opinion.
Specifically about recommendation on.
It incorporates recommendation 1 in 5 overarching principles for the universal health.
Oh, right.
So it kind of puts them all together and just streamlines them a little bit. And so, yeah, I'm just curious what other board members think.
is there a way to pull that up for another? In the public comments?
I'm gonna leave it up to
Uh,
the committee to decide if we want to consider this for.
Yes, I guess what I would suggest in the light of this discussion, and I think we're all committed to the principles,
Yes.
but since we're all just wanting to be sure we have the right words, I would, and in the light of time, I would defer this to the or table it to the next, to the August board meeting.
And we all spent some time looking at the public comment.
I'm fine with that.
So
If everyone.
we're
is-
not gonna go through this today then.
Yeah, if everybody is in
Got it up
agreement,
there.
we'll just table this. Okay,
So yes, I'll ask everyone to read through the testimony that from Tom Sincic, which is on our website and also.
In our agenda.
Yes.
Yep, it's on the website,
Yeah.
and it's easily accessible.
Where would it be?
It's
On the
under the
web-
meeting materials for the July 18th meeting.
It's under public comment. So the public comment is all grouped together in one single PDF document.
Yeah.
And it's in there.
Click on the link.
Saw that, I just hadn't seen anything on equity. But maybe I
It was
missed
the
it.
5 overarching principles of the universal health plan.
Great, good call, Michelle. And,
Yeah.
just, I think there's still a motion on the table.
Yes, there's a motion on the table to approve this recommendation and it's been seconded.
Are we gonna pause it now?
Um,
We're gonna table it, and we'll table a vote on this decision until August.
Yes.
Okay,
I withdraw the motion.
okay.
I take back my second.
Okay. Great. Okay, so, couple more agenda items. We were hoping to review and officially approve the work plan. Again, this is in service of bringing on a contractor and communicating clearly about our work plan. I'm gonna hand it over to Morgan to explain a couple of changes to the work plan.
Sure, thank you. Just a quick review, the changes to the work plan, include feedback that we received at the last board meeting that has been included. In addition, prior to that, there were 2 work group meetings that got feedback on the work plan. And since the last board meeting, staff has been meeting with board members who have volunteered for each of the committees to also start thinking through the work stream, the tasks and the deliverables. And so the feedback that is, and the changes incorporated in the work plan are a product of all of that work. So a couple of minor changes in this slide, you'll see this is very much very close to the slide that you saw last time with some change to the timeline of the transition plan. And so that was made. Next slide, please. You'll see this is the visual. We've updated the deliverables. In addition, I would and we got lots of feedback at the last board meeting about the expertise needed, and those that language has been updated. In addition, one of the recommendations from the board members who volunteered for the operations and transitions group was that, and we'll talk about this more in the committee charters, but was to separate that work out so that it's not connected in the same committee. That there are 2 committees instead of 1, instead of an operations and transition, that there would be an operations committee that we would be talking about creating today, and then a transitions committee that would be created at a later date. So in the visual, you'll see the committee for the transitions work stream. It says transition committee, so that's a change here. Next slide. And then summary, there are changes to work stream number 3 in the financing. There are changes in the work stream number 5 in the operations, which include the tasks and deliverables. And then changes in work stream 6 in the tasks and deliverables and timeline, as I mentioned. And once we updated the documents, then we updated the charters. So when you looked at the charters, those changes are incorporated, and then we updated the visuals. So the idea is that all 3 documents are aligned with the same tasks and deliverables. Next slide, please. So here's a motion to start the conversation. And then I did include here, I think there's been lots of conversation about this being a living document or an iterative work, that along the way, there's going to be additional work that we uncovered or questions we need answered. So I included, not as part of the motion, but just so that we can see the language, at a minimum, staff recommends reviewing the work plan quarterly to track progress and identify additional tasks and deliverables as needed, so that there would be a specific agenda item, you know, every 3 months, where we would come back and say, here's the progress, here's what we're hearing from the committees. And it would be would be identified time to look at the work plan, not necessarily just updates from the committees, which I assume will also be happening.
So I'm not sure how we're working this procedurally. I have 3 changes that I would like to make to the work plan. And we can handle those one by one, and then I guess approve the plan as amended. So the first of these 3 changes that I'm asking for is we've to add a task, add a couple of tasks actually to the foundation phase. And I think that's important, that we select general financing structures for universal care to be analyzed for potential recommendation and implementation by the governance board. And by that, I mean, we really need to put together, are we going to go for a full single payer? Are we going to have some sort of modified plan where some revenue streams are in and others are out? The SB 1089 actually gives us a pretty wide road, including doing things to place restrictions on private insurance companies to standardize things. So I think that we need to be, we need to arrive at some clarity of what we're trying to do. And I think that's really important before we get too far into the RFPs and RFQs. So I'm asking the two tasks be inserted in the, and to me, it's part of that, our foundational work. So it's just kind of as a final act that we need to set certain expectations of where we're going. And would you like the specific wording on that?
Do you want to discuss it first or do it? I don't know. You tell me.
So very briefly, you want to review financial models for building the plan? Is that, like, can you say your one short phrase? Like, what's the first one? Just for Katie needs to write something down of what the change you're asking.
That we need, that the board needs to select the general financing structures.
Okay,
Which we will be studying and implement and recommending the implementation.
okay, and then.
And actually, as a sub part of that, I think it would be really helpful if when we're thinking about, you know, why are we doing this? Are we doing it to save money? Are we doing this to increase services? The task force kind of took a statement that would have worked out with about 80% of our savings would go into increased services. So I think that it would be very helpful if we all agreed and understood. So I'm asking for those two, additions.
So the second one would be then to clarify where any savings would be allocated?
Would be applied. Yes, make tentative decision on how potential savings of universal care would be applied.
Okay, so those are the two changes, and these would be changes to the financial works.
No, because this is not just financial.
Okay,
This is, everybody needs to make, so I would put it in the foundation plan, which will end up in August, and the way that I would foresee implementing this, that as soon as we see the additional committee members in August, that we would form a work group of committee members and board members to talk about this and come back with recommendation at September board meeting. But
so these aren't changes to the work plan specifically, or they are?
yes,
Okay, where in the work plan is it? Oh, in the foundational.
In
So
phase one.
this is right, that document, that's just the phase two, so you're talking about it in phase one. Got it, okay.
thank you. Thank you.
Can I just clarify one? You're not talking about financing as much as you're talking about eligibility, right? I mean,
Well,
what
I'm
groups are in?
talking
and-
about, you know, a lot of people are asking is, what are you gonna do? Are you gonna do mandatory private insurance? Are you going to try for a full single payer plan?
Got it.
And I think we need to have some clarity.
I would agree.
And, you know, it's not that we have to choose one, but if we're gonna like search for five, then we have to consider that in the data that we're gathering. So I just think it's important that we reach that, have at least a preliminary clarity that we can use for.
So it's almost like the modeling and having different models that we're looking at.
Well,
Because it's beyond,
it has applications for every committee,
Yes.
but certainly
yes.
certainly for the revenue portion, it's kind of a huge thing.
Well,
Is
and for-
Medicare in or out?
Yeah.
Those sorts of questions. So I think this will
And
help us to talk about those early. So that we have an idea.
and to responding to questions like, are people still gonna be on OHP? So,
Yes.
so I don't, is it financing structures or is it, it's kind of like it's like kind of the modeling, or I don't know.
Yes, I tend to think of what we're doing is really, we're working on the finance part of healthcare rather than the delivery part of healthcare. So I think of it as a financing.
Yeah, and I think of it as which services are people potentially gonna lose and how is that gonna impact access? So like, kind of different angles.
And it's not separate from what we were just talking about like we've had these recommendations from the task force of how to do it, and we have to decide how much of that is what we're gonna do. To me, it seems really similar to that and kind of part of the same work. And somebody brought up in that discussion that maybe we need a work group to kind of sort through those.
Yeah, so we're not voting on the work group here. That would be an issue for August. But just having that in the work plan.
To recognize in the work plan that we need clarity on what the full structure of this, the universal plan is gonna be and where any savings would be. That we need to work that out a little bit more.
Yes.
Be helpful maybe if staff came to the next meeting outlining a number of options.
Or, I think yes, I've just identified several. But yeah, we can get that on the agenda for next. The main thing is I'm just looking for approval from the rest of you to add this to the work plan.
And what I heard was, to add, this is a task to the phase one work, and I think Bruce gave a suggestion of how to do that, and others, we can have the discussion at a board meeting here, different models, are we missing anything? And then send it to a work group to come up, with some recommendation for the board to consider in September.
Well said.
Great. So requested changes to this motion are to add 2 tasks to phase 1 of the work plan, and then those 2 bullets.
Ready?
Yes, is any other questions or comments? Is there a motion to approve the work plan?
Yes, I'm happy to make the motion.
Is there a second?
Second,
Any discussion? Okay, let's do a roll call vote to approve the work plan with these requested changes.
Helen Blanca,
Yes.
Chun-Wei Chi,
Yes.
Debbie Diaz,
Yes.
Amy Fellows.
Yes.
Warren George,
Yes.
Michelle Glass,
Yes.
Bruce Goldberg,
yes,
Judy Richardson.
Yes.
And Cheryl did step out for a moment, so I don't know what we do in that case.
Well, she's not here right now, and she's still at the meeting, so, we'll capture her vote at the end of the meeting, we can ask her when she's
Okay.
here.
Perfect.
Okay, so, final item on our agenda, oh, no, not quite, but yeah, we're getting, close. Oh, so before we move on, Cheryl, we just took a vote to, that's okay, to, approve the work plan with a suggestion addition of 2 tasks to phase 1. We can go back one slide, Katie. So there was a motion to approve, the work plan with requested change to add 2 tasks to phase 1 of the work plan, talking about a general structure for what we're doing and then clarifying where any savings would be applied.
I vote yes.
Okay. Okay, so now we're gonna go ahead and talk about the work to establish the communities.
Great, so, the work plan outlines the work stream, but doesn't really talk about how the work would be accomplished. So we need the board to consider approving and establishing the committees that, by the way, we're already recruiting for, through the committee charters. And, next slide, please. Just to update some of the changes that have been made to the committee charter since the last board meeting. During the June board meeting, it was requested to add language about how decisions of the committee, in the recommendations that they're making to the board, how that could be made. I slightly modified the language from the board's policies, to, be used in the committee structure. In, adapting that language, I realized that we need some definition of quorum, like for the committee to do the business, to make recommendations to the board. So additional language around quorum was added. And then in some conversation with Jake Gill, our attorney, he suggested that we add some language around kind of the existence of the committees. So there's language in the committees that says the board can dissolve the committee, that the board has the authority to replace or remove committee members. You know, if somebody's appointed to the committee but then never shows up and it's harder to get a quorum, you could imagine a situation where the board may need or want to step in. So there's some general kind of like how the committee would operate language that's new in these committee charters. And then, as I mentioned previously, the tasks and deliverables have been updated in the committee charters to reflect the tasks and deliverables that are in the work plan that you just approved. I think the one piece is that when the board members were talking about the operations body of work, that there was discussion about how the expertise needed to do that work was very different than the expertise needed to think about the transition and implementation plan. So that body of work has been removed from the committee charter, and we're not asking for approval of that committee today, really to focus on the 4 committees. And then we will come back at a later time and ask for the board to approve that committee and have a kind of a more focused conversation about the committee membership. And at a later date, we'll also need to do the recruitment for that committee. So today, the action that we're requesting is to approve the 4 committees as governed by the committee charters that are dated July 15th and posted on the website and linked in your board agenda.
I'm looking for a motion to establish 4 committees: community engagement, finance and revenue, plan design and expenditures, and operations. And so Cheryl's moved to that as a second.
And should we specify community engagement and communication?
Sure, community engagement and communication. Is the official name now. And there was a second. Yes, oh, Michelle seconded. Any discussion? Okay, we'll do a roll call vote.
Helen Belanca,
Yes.
Chen Wei Chi,
Yes.
Diaz,
Yes.
Amy Fellows.
Yes.
Warren George.
Yes.
Michelle Glass,
Yes.
Bruce Goldberg,
Yes.
Judy Richardson,
Yes.
Cheryl Ramirez.
Yes.
Thank you.
Great. And one more time to Morgan to talk about committee recruitment.
Yes, so thank you. So as I mentioned, we are currently recruiting for committees. I just want to share a little bit of the outreach that's been done thus far. The communications team at DCBS sent out a press release when our application process, well, they helped us in developing the application and put that on the website. And then on the day when the application went live, they sent a press release that went to 1,000 media outlets and organizations. We did get 1 media coverage. They just printed our press release, kind of establishing and recruiting for the committees. In addition, Katie sent it out on our bulletin list, which goes out to 250 people who have opted in and who are already tracking and engaging in the Universal Health Plan Governance Board. Helen and Warren and I have met and talked about outreach to organizations who have engaged in the creation of the Universal Health Plan Governance Board, either through legislative testimony or letters of support. So to do that outreach to organizations who have already been engaging in past work. And I know that you all have been sending it out to your networks, and several of you have shared who you've been sending it to. And I'm happy to report so far, a week and a half in, we have 21 applications. They cover all 4 committees, and we asked if you had a preference for your for the committee you'd like to be, and then to rank if you were interested in more than one committee. And many of the applicants have indicated that they'd be interested in more than one committee. In addition, we have 5 people who have indicated a preference for community engagement, 3 people who have indicated a preference for finance, 7 people who have indicated a preference for plan design, and 2 people who have indicated a preference for operations, which I think shows that we're getting interest in all of the committees, which is a really great place to be with a little over a week to go in recruitment. 2 did not specify a preference. In terms of where people are applying for, many of the applicants are from the Portland area, but we also have Hood River, Albany, Lebanon, McMinnville, Eugene, Corvallis, and the Dalles covered in the applicants. So still more work to do, but I'm very pleased to see that we're getting applications already.
Yeah, I guess I'm not as optimistic. 20 people, I was hoping for a couple of hundred. I think I've talked to a number of people. I was surprised by the number of people who didn't get an email, etc. I don't know that our individual outreach is enough. I would think, number one, we could have DCBS send the announcement out to everyone on their mailing list. I'm sure that's actually several thousand people. We could do the same for OHA. We could do the same for unions. We could do the same for AARP. We could do the same for the OMA. We could do the same for the Hospital Association. I just think this gets at community engagement. I mean, we've got to create a large net, communities of color, consumer groups. I think we need to get that input on our committees. And if we don't, we're really going to sort of fall short. So I'd love to see where this announcement, a press release is great, but I don't think any newspapers printed a story about that. So I think we need to counter, sending it to every person in Cheryl's behavioral health mailing list. I just think that we could up our recruitment a bit and perhaps extend the time frame a week or 2. 20 people just doesn't sound so great to me. I mean, I know it's been a lot of work and it's been great, and I don't mean to be critical about it, but I think we could do a little better in terms of recruiting people. I've just been surprised at the kind of folks who when I reached out to people, my first question is, did you know about it? And they hadn't. So I just think that's really important.
Would it be helpful if we drafted recruiting? Yeah, so we can reach out. We are in the process of reaching out to many of those groups that you mentioned one-on-one and talking to them one-on-one too, and asking them to communicate their network. But it really is up to all of us to tap into the folks that we know and organizations, the bigger organizations between Warren and I, we've got some of those covered. So we could also draft a recruiting email. So on our website is a letter from me about the work, and then the link to the application. I don't know if any of you've been there, seen the letter, seen the application link. Okay, great. So, if you can do direct outreach to folks who would you want to be involved in this? Either talk to them directly, set up a one-on-one meeting with them, send emails out to listservs or whatever groups, that you have, because the more people, which is right, the more people who get engaged, the better. Do you need more than what's there already? Do you need us to draft a recruiting email? You guys got that? You got that? Okay, good. You know where to find?
I think it would be
links?
helpful.
Oh, you do? Okay, so yeah, we can.
Yeah, and the other thing I wanted to suggest is, our next board meeting is when you would be potentially appointing people to the committees. So if you wanted to, recommend, extending the deadline for a couple of weeks. If we don't receive X number of applicants by the deadline, staff, please extend it. There may be a threshold you want to set, because this is the board meeting where you give us direction and we can go operate that. So otherwise, I think, that may be something you want to discuss here today, if you want us to do that extension.
Right, the other thing to consider is the committees don't all launch at the same time. There's a little bit of staggering, and what we had decided on in our timeframe was that the finance committee and the community engagement committees were important to get up and running quickly. And so trying to focus first and foremost on recruiting those. The plan design and expenditures and operations committee probably aren't gonna launch until fall. We just need a little bit of staggered time to get things going, and so extending the timeline particularly for those two committees makes sense to me. In addition, we had talked about that it wasn't necessarily a closed process, like this isn't the only time that you could become part of this committee, that we have some process for pulling people on board later if someone expressed an interest, or we felt like we needed some expertise that we didn't have on the committee, that we could do some targeted recruiting later on. So it's not necessarily a closed process, but yes, if the board would like to, so right now the current deadline to apply to the committees is July 27th, I believe, 28th. And so if the board would like to extend that for all of the committees or some of the committees, we can decide that now, or we can see what we have by the 28th and then decide at our next.
How long will it take to get the organizations I just mentioned and several more outreach to?
Many of the organizations that you suggested, I've already been in contact with and asked them to share with their members. I just don't have the information back that that's happened. So I don't think having conversations with many of the organizations that you suggested would take a lot of time. I think it's then rolling it out and then getting people to see it so.
What I'm finding is, many of these groups want to have a one-on-one discussion about what the heck we're doing. Which is kind of understandable. There hasn't been a lot of, would you say, would you help recruit and send this email out to your membership? It's like, wait, can we set up a meeting to talk about it? So it does become a little bit more of a stepwise where, we're having to work around our schedules and set up meetings first before but hopefully, yes, then the goal is.
So that would point to extending things.
Yes.
And I would, based on this conversation, I would recommend that we extend it to the Monday of our August board meeting, so then we can come to the board meeting, share how the recruitment is, how many applications we have. And then at that point, not be appointing people to committees, but have either look as a board, having a special meeting at the beginning of August or September. Kind of so that we could still get committees up and going in September, but we could find a time to have a special meeting just for the purpose of appointing people to the committee, and that would give us a couple extra weeks.
That's a good idea. Yes, Michelle.
I fully support that recommendation. I think that makes good sense. 2 quick points. One, in reading the task force report, some consistent feedback that stood out to me was the strong desire for diverse representation in this process. We think we have a lot of work to do, and I don't think that happens easily. And the second point is, I've done a first round of outreach to a bunch of people, and I'm getting ready to do a second and a third. So I don't think one e-blast, one email, one phone call, one text is going to do it. I think probably most of us here had multiple conversations with people that got us to this table, and so I think that it's going to take repeated conversations for most folks in order to result in an application. So just wanted to say that as well.
Yes, especially given that it's summer. Yes.
That
All
too.
part of the summer. So I'd like to move that we extend the deadline for applications for all 4 committees to the Monday before our August meeting, and the date of that is August 12th.
Thank you.
Thank you. Okay. Any other thoughts, discussion on committee recruitment? I don't know. I'm not sure that was super clear. Feedback.
On once they're submitted, like the process of deciding who's on it?
Yes. So, what we've talked about so far, and this is again up for discussion, but the staff will, collate all the applications for various committees, and then the staff will make recommendations to the board for who to appoint, based on thorough review of everybody's applications. But each committee will get the full list of people who applied to be on that committee and the staff recommendations for whom to choose, and then it'll be up to each committee to select those. So right now, all 4 committees have at least 2 board members on them. And so considering your charter and your deliverables, you'll see everybody that applied and then who the staff recommended, and then you will have the final say.
Okay, thanks for reviewing that again.
Yeah. Great. Also a LinkedIn, is everybody following the DCPS site? Yeah, okay. So posting, if you're on LinkedIn, posting, which is a great, source for that, so you can just repost what is posted on the DCPS LinkedIn site.
Okay.
So it's nice, it's everything. Cool. Any other thoughts or discussion on committee recruitment?
I think we need to get to public comment.
Yes. We have 10 minutes remaining. We have one person who has signed up for public testimony, Mr. Richard Walsh.
And just so you know, one person in here, but then we have 3 people online.
Oh, there's 3 people on, I didn't know that. Okay, great. So that means, so we have 4 people total. We've got about 10 minutes. We can go over by a couple minutes. So I'll ask each of our speakers to limit your comments to about 3 minutes if you can, so we can hear from everybody. Great. David, you want to start? Or Richard, sorry, start.
Hello, everyone. Hello, everyone. My name is Richard Walsh. I'm a local attorney here in town and I do personal injury work. And so we deal with insurance companies extensively for the last 35 years. I've testified here once before, so I'm not going to go over everything again. But I do want to say that I've seen the goals, I've seen the discussions and everything. And I just want to emphasize that the #1 goal that really isn't being talked about is how do we get this passed? You know, how do we address the voters? You know, I mean, I know we want to deal with the communities that have been disadvantaged and underrepresented, and we want to deal with the people that have been shut out. We want to deal with all the different areas and groups. Absolutely. And we want to deal with people that don't have resources and don't have benefits. But we also have to deal with the people that are pulling the strings. We got to deal with the people that are the interest groups. We got to deal with the voters. We got to deal with the people that are going to pass this ballot measure or throw it down the toilet. I mean, we've seen these kind of things fail because people have great ideas and wonderful plans that just cost more than the voters willing to pay. And I don't know if there's enough emphasis being put on balancing getting this thing passed to the legislators, to the interest groups, to the people that pull the strings, and from the voters. So we have a wonderful package. We actually have, and this is what we've been trying to sell, and this is what we've been trying to tell people, is that universal health care can provide better service at lower cost. So our challenge is to prove that to the individual voter. And so if you could go to a voter and say, we can give you what we promised, if we can give you better service at lower cost to you and your family, then they're going to vote for it. And if you tell them you're going to get worse service for them and their family, or it's going to cost them a little bit more, they're not going to vote for it. It's that simple. And if this thing goes down in 2026, doesn't get to the legislature, it's not coming back in our political lifetimes. I mean, we're going to have one shot at this thing. And so I can't emphasize enough that, you know, that's our primary goal is what's the best we can do to actually sell? And so I really do think that people are going to ask what's going to cost me and what's going to get. So when I went door to door, everyone, not everyone, but almost everyone was in agreement. If I could get what the governor gets and the PED benefits, if I can get what the governor gets and the legislators get, by God, that's better than what I get. So yes, I'll vote for that. What's it going to cost me? And if we can say your net benefit will be X, then they'll say, well, yes, of course, that's what they all say. We have to prove that to them. And we can get net benefit to them because we are spending, everyone who's, the person you have to convince is the majority of people who are on insurance, are happy with their plan, or they're on public assistance and they're happy with that. And they're not going to vote for a change into something that they don't know about unless they're convinced that it's going to help them. So we have to put a lot of work into the legal aspects that how do we make it a net benefit for individual people? And I think you can do that because most people are getting $800, $900, $1,000 worth of benefits from their employer. how do we get that money to them in the form of a mandatory raise? Or, you know, I mean, that's a legal thing. How do we get that money to them in terms of incentives, in terms of a raise, in terms of something, so they can say, oh, well, I'm not gonna have my health plan anymore, but I'm gonna get $800 a month raise. Oh, I'm gonna get a tax, it's gonna cost me $200 a month. Great, it's still a net benefit. What's my package? I'm gonna have the same thing the governor has. Great. Those are the kind of discussions, and that's the kind of work that needs to be done to figure this out. And to do that, we have to keep the costs down as much as possible so we can realize those savings. And we have to have the benefits at least to pass, not to be the best plan possible. So, and then I was thinking about that, and the way we could do that, and we've done this before in Oregon, is that we don't have to have one plan. We can have a basic plan, which is pet benefits, period. You can grandfather in people on current plans and stuff for transition. And you can, and on the Oregon Health Plan, and you can have other things like a special, you know, bonus card for everybody who's on Oregon Health Plan, so they don't have to pay for co-pays and deductibles and so on. So you can make little adjustments to it, but basically keep it as minimal as possible. And then if you have another plan where you have long-term care, nursing care, whatever, all these other things, all the mental health care that you could possibly want, anything else, fine, put them into a second package. And then we'll have the gold plan that people can vote for, or they can vote for the basic plan. And people are used to that. And they'll go to the votes and they can do that. And then if they vote for the basic plan, then great. If they vote for the basic plan and the gold plan, then they'll get the gold plan. And then people can start rallying for what they want. And the people that are like, I don't want you to pay for, you know, whatever, you know, X, I don't think that's appropriate. Fine, then vote for the basic plan. At least we'll get something passed. And then once something's passed, if people like their plan and they like the fact that they're not tied to employment, then they'll vote to approve it. And then the legislators who are stuck to the same plan, they'll vote to approve it too, because it's their plan too. Anyway, I don't want to take up too much time, but these are
Thank
things that
you, Mr. Wall. We appreciate you coming back for your comments. Thank you.
Thank you.
Thank you. Next, public comment, David Ladwig.
Hi, yeah, this is sort of an addendum to what I wrote down about having measurement, but measurement toward a better system and not losing sight that we're not just about single payer, we're about better healthcare, and single payer is the first step on that way. A lot of the baseline data for better healthcare can be achieved from using the all payroll claims data that's out there. Get a baseline, and then just some suggested measures, like not that I'm for these strongly or against these strongly, but examples would be how many people have seen a primary care physician for like a basic physical to get their baseline data. Number two, chronic care patients with chronic diseases, and are they being cared for properly? To try to keep them out of the hospital multiple times down the road. And then third, in the late 90s, I was working for Harvard Pilgrim, and we looked at patients that had been admitted for a substance abuse diagnosis to the hospital or depression. And I looked at how much more medical care had those patients used. And it ran from 70% more to 700% more. So not only should we have better mental health, behavioral health care, but it should be better integrated with healthcare in general. And that's my basic comments.
Thank you so much, Mr. Ladwig. That's really helpful. Thank you.
Yes, thank you, David. Next public comment, Dr. Vern Sabot.
Yes, good morning, afternoon. So the one issue that I wanted to discuss relative to a universal health plan is relative to reimbursement. And I'll touch upon coverage and participation as well. But the reason why I say reimbursement is currently I'm still the only chiropractic physician in Albany that accepts Oregon Health Plan patients, specifically through Samaritan IHN CCO. And this is because of the low reimbursement rates, less than half our normal fees. And we're treating the working poor. I wondered what I was getting into when I first got into it, but it's now I know what that term means, working poor. And the folks are so absolutely thankful for the care, and the outcomes are wonderful. Now, just a little history of myself, how I'm involved in this. This started back in 2010. when we went to then U.S. Senator Tom Harkin from Iowa, who treats with my good friend F. Dal Bates. And our coalition of non-MD healthcare providers said we've got to not allow insurers and health plans to discriminate against healthcare providers based on their type of license. If in fact a healthcare benefit is within our scope of practice or license to provide, we need to be paid for it. We need all hands on deck. We need to be paid with parity. And we need to be able to participate. It was, and he agreed, and it became the Harkin Amendment, which then passed and became Section 2706 of the Accountable Care Act, which passed in 2010. Following that, we went to Governor Kitzhaber on his CCO bill. I served on his health systems transformation team that we created the CCOs. And in 2012, we went to him saying, this same non-discrimination for healthcare providers needs to be applied to CCOs. He agreed. That was passed in 2012. And essentially, what we want to ensure, so we get all hands on deck, you get participation, is reimbursement has to be reasonable. And I spoke with Dr. Goldberg about this a number of months ago, and apparently the task force talked about a reimbursement, fee-for-service reimbursement, somewhere between the commercial health insurer rates and the Oregon Health Plan Medicaid rates, somewhere in between that. And that's getting reasonable. But we want to, as a profession, the Oregon Chiropractic Association would say that if you're going to get participation, you cannot allow discrimination against healthcare provider types, or you're just not going to get them involved. They'll end up becoming crash practices outside the system, which is a lot of what happened in Canada. And so the language is stating similar non-discrimination. They can see the healthcare provider of their choice. Does that mean this is going to be an any willing provider system? Hopefully it will. That means any willing provider of whatever discipline who's willing to follow the rules, the guidelines, must be allowed to participate in this state universal health plan. And coverage, if it's with a covered benefit and it's with that healthcare provider's scope of license to provide, they provide it, they've got to be paid for it. You can't say, well, we just don't tend to pay chiropractors for interpretation of lab work or whatever that is, or naturopaths or whatever it is. And finally, the reimbursement has to be reasonable, not discriminatory. And we would say it would be best to be based on quality or performance measures, outcomes. Do a better job, you get a bonus. You do a better job, you get paid more. You do a crappy job, you can be bounced from the system. Appreciate your time. Thanks so much.
Thank you, Dr. Sewell. Appreciate it.
And our last public comment is from Tom Sinzik.
Okay, I'm going to thank you first of all for your extra time today. I want to say that my name is Tom Sinzik. I'm a retired family nurse practitioner. I very much enjoyed the thoughtful deliberations and the considerations. I'll go through my little checklist very quickly. I shared a little document about a cost-saving item, and this is called a muscle scraper. This is the one that's $10.99 delivered to your home. The $2,000 one is the one purchased in a clinic system. Wow, think about that, $1,989.01 savings. It was great to hear this values, and thank you for taking consideration of what I had submitted. Appreciate that very much. It does tie into the issue of the what you were talking about before you talked about the values. I think it's very important that you adopt the values first and then adopt the what's that you were talking about that you've tabled for the moment. So, and I emailed next day was the budget. That was a very good discussion about where the budget is going. I asked a question in an email I sent to Morgan and the chairs. Maybe Morgan, you could forward that to the board you already have, which is, what is there needed funding now? Senator Manning is very interested in the issue, as you know, is there an ask that could come now if it's needed? I wasn't here to judge whether it was needed or not, but I think if there is an additional funding that's needed now, then there needs to be a system for going ahead, and I'd like to get interested in an answer at some point about that. And Senator Manning would be very interested in that too, even though I don't speak for it. Senator Manning, I did speak to Senator Manning. The next item was just comments, a couple of things. How do you get this thing passed? Community engagement. So that was a really good presentation on community engagement. That's why we are where we are. And the comment was brought up with the Colorado thing. That's why Colorado failed of all things. We did a careful discussion. I did a recent presentation to Colorado on that. It was the failure of community engagement, particularly in that state. It's really great to know that California, you're talking to California and what they're doing over there. I want to alert you to Washington State is picking up theirs. So maybe you want to go ahead and do a little outreach at some point in a discussion to say, well, should we make a contact with the people in Washington State? They have a commission as well. And yes, in closing, I guess I think the thing is, yes, for Vern, any willing provider, yes, there should be fair pay. I don't think there's going to be a question about that. Know that going back to this is we got a constitutional amendment passed in this state. That's a framework. You know, people are with us, and I don't think it's the role of the advocates going forward to figure out, and the legislature to figure out how to move this thing forward, but for this board to just focus in on the core work that they need to do. Thank you very much.
Thank you so much, Tom, for your comments and your involvement in our work. We really appreciate it. Great. So we have our final closing quote, which I think is familiar to all of us, from Reverend Dr. Martin Luther King: "Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane." Whose pick was that? Do you know? Was it yours? Okay, so
Just in case no one else.
Great. So you wish we get a volunteer. So it can be a quote, it can be a story, it could be a reflection of some sort, it could be a poem, it could be anything. We've had all quotes so far, but is anyone willing to be the closing thought for next meeting?
I'll do it.
Awesome. Judy will do it. Great, thank you.
For August.
For August, yes, yes. And yes, so I just want to reiterate, we're so happy to have comment from the public on this through our formal public comment processes. We also have been getting emails, as Tom mentioned, from several members of the public, not through the formal public engagement process, but sending emails to the board, which we really appreciate. We do read those and appreciate them. We encourage everyone to submit comments to us in whatever way they feel they want to. The public comment will be on the record, so we really appreciate that. Thank you all very much for coming and for your participation, and you'll hear from us soon, and we'll see you in August.
Good meeting. Thanks, Alex.
Great, thanks.
Do we stay here for our ethics training?
Yep, the